we should just bow our heads in silence for all those people who are fighting our battles for us. Yesterday, my PG said they fainted. Two of them fell in the PPE kits. Just let's ask God for blessings before we start this academic activity.
Okay. Just a minute of prayer.
Yes, please.
Thank you. Welcome to the participants of this Ophthalmology Reboot, which is a 2-day, 6-session refresher course organized by the Cochin Ophthalmic Club and the Kerala Society of Ophthalmic Surgeons. We have great pleasure in inviting all the speakers and all the delegates to this virtual conference. Let me introduce myself. I am Dr. Sai Kumar. I work in Giridhar Eye Institute in Cochin. I am the president of the Cochin Ophthalmic Club, and along with my team, which is my secretary, Dr. Gopal, Dr. Thomas Arun, Dr. Soni, we have great pleasure in welcoming everyone to this meeting. It was actually Dr. Gopal's idea to have a session like this, and we have an array of great personalities, great speakers in each subspecialty in glaucoma, and I'm thankful to everyone for having joined this particular conference. And without much delay, we will go on to the actual proceedings of the conference. Before that, I also have to mention about Dr. Rajiv Sukumaran, who's the chairman of the scientific committee of the KSOS, Dr. Prashobh Mohan and Dr. John Davis, my colleagues in Cochin Ophthalmic Club, who have taken a lot of pain, lot of effort to put the Zoom meeting together, connected to YouTube Live, connected to Facebook Live, and so that it reaches out to a really large audience all over the country. I request the president of the Kerala Society of Ophthalmic Surgeons, Dr. Meena Chakrabarti, madam, to say a few words and officially inaugurate this Ophthalmology Reboot refresher course, which I'm sure will be useful to all the delegates all over the country and abroad. Meena, madam.
Thank you, Sai. Dear friends, a warm welcome to each and every one of you attending the Zoom online meeting, which is organized jointly by the Kerala Society of Ophthalmic Surgeons and the Cochin Ophthalmic Club. This 2-day webinar, rightly named Ophthalmology Reboot, will cover all relevant aspects in all the subspecialties of ophthalmology. It is aimed to benefit not only the postgraduate students, but also our junior colleagues. The mode of presentation will definitely be a boon to the postgraduate students, and my sincere request to the postgraduates is to listen, take down notes, go back and read, prepare your own notes. You can come back and listen to the recorded version at any time. I take this opportunity to congratulate Dr. Gopal and Dr. Sai for this excellent initiative. I also thank Dr. Rajiv Sukumaran, my own team member, for the technical support that he has given. The thanks are also due to the Milmet Sun Pharma for their contribution in this educational effort. On behalf of the Kerala Society of Ophthalmic Surgeons and as its president, I declare the meeting as inaugurated, and I wish each and every one of you a very wonderful day. Thank you very much.
Thank you so much, madam. I now request Dr. Gopal Pillai, Secretary of the Cochin Ophthalmic Club, to just brief about the technical aspects of the meeting, and then Mr. Raju will also say a few words on behalf of Milmet. Dr. Gopal, please.
Thank you very much, sir. Am I audible?
Yes, yes.
Yeah. Thank you very much for joining us. This is the first of 6 modules. We have the best of the best in the country as faculty, and as far as postgraduate, as well as this is not packaged for postgraduates, but packaged for the entire ophthalmologists. So these are not theoretical topics. These are clinical as well as more clinically relevant topics, and all of you can ensure that you are in the teaching mode rather than in lecture mode showing a lot of things. Now these 6 modules are one is glaucoma, second is pediatric ophthalmology and neuro-ophthalmology, third is retina, fourth is cornea, then we have plasty and uveitis, and then finally cataract. So each of these modules, you should understand that the glaucoma module right now runs between, right now it is 9:15, so 9:15 to 12:15. The next module starts only at 2. So you have some buffer time. So make sure that you use this time really well. And these presentations and these discussions will be in YouTube for all the postgraduates and all the ophthalmologists to see for years together. So make sure that this is a wonderful teaching session. Each of these, we have the stalwarts directing these courses. Like the glaucoma is directed by Dr. Andrew Braganza and Dr. Kirti Singh, and moderated by none other than our vibrant Krishna Prasad. Like the pediatric ophthalmology program is directed by Dr. Pradeep Sharma. The retina program again by Dr. Lalit Verma, Dr. Meena Madam, and Dr. Giridhar. Cornea again by Dr. Koresh Maskati. Uveitis by Dr. Jyotirmay Bishwas. Plasty by Dr. A.K. Grover, and cataract by Dr. Arup Chakrabarti. So you see, we have a star-studded program, and I hope that these 2 days will be immensely beneficial. And such a 2-day webinar, there's a lot of technical glitches, and we understand the tension involved in John and Prashov and Rajiv Sukumaran sir when the program could not start in time. We are with you, and we understand that this is the first time it is being attempted like something like this. Let's all think that this will be a wonderful program. Thank you very much. Over to Dr. Andrew Braganza and Dr.
Can I ask Mr. Raju to just speak a few words on behalf of Milmet Sun Pharma before we actually start the program? Mr. Raju?
Good morning, good morning, doctors. Good morning. Thank you very much for this opportunity to associate with one of the novel program, which is a 2 days virtual program for all the doctors. So thank you very much giving this opportunity to us. We are always with this support for the scientific program. Thank you very much. Thank you.
So request Dr. Andrew and Dr. Kirti Madam to please take over proceedings, and we'll start with the glaucoma session.
Hello, can you hear me?
Kirti Madam, you're muted. Yeah.
Okay,
yes,
sorry. Yeah. Thank you for having me here in this session. It's in God's own country, sitting from Delhi. So, but I believe right now we only have 20 participants, so most of them is us. So the residents will probably be listening to it in the recorded version. And I always believe when we do our teaching, we learn ourselves. So there's no age for stopping learning. So let's start learning. Andrew, is he there? Yeah.
I'm here.
You want to carry forward?
Yeah, I'm just looking at who is the first person.
Kiran Gopalakrishnan will be speaking.
First is Kiran.
Yes. Okay, so Kiran, go ahead. Hello.
Just to introduce Kiran, Kiran is, he studied in the Orient Institute of Sciences and he finished his glaucoma fellowship there. And he has come to Trivandrum and is a consultant in glaucoma over last 15 years. Over to you, Kiran.
Kiran, you can share your screen.
Kiran, can you hear us? I can see him.
Okay, so Kiran is leaving and rejoining. Can we have Dr. Thomas George have his second presentation? Art of gonioscopy. Dr. Thomas George is trained at CMC Vellore, and after a long stint in Medical College, Government Medical College Trivandrum, into glaucoma. Now he is a consultant of glaucoma in Chaitanya Eye Hospital, Trivandrum. Can Dr. Thomas share your screen?
Good morning. Thanks to COC and KSOS, customer, thank you. And when you say the art of gonioscopy, you're taking out some parts of it which I'm a little upset about. So I prefer to go for the science and technique. I'll primarily be talking about how to do a gonioscopy, then go into a little bit of clinical data so that it puts it in perspective. Of course, any procedures should start with telling the patient what to expect. So explain the procedure to the patient. A topical anesthetic is instilled, and the patient should be seated at a slit lamp. Make sure the stools are appropriately height adjusted so the patient and surgeon do not have neck pain at the end of it. With a Zeiss or a Sussman, that's a 4-mirror lenses, they have a smaller area of contact. You don't need a coupling fluid. You ask the patient to look straight ahead and insert the lens to touch the tear strip. I say touch because any amount of pressure would, one, indent open the angle, two, it will cause Descemet's folds and obscure the angle view for you also. With a Goldman lens, I prefer a single or a 2-mirror lens. I'll come to that a little later. With a Goldman lens, you ask the patient to look down, place the edge of the lens at the inferior limbus so that you can use that as a retractor for the lower lid, and you rotate the lens onto the cornea and ask the patient to look straight ahead. Alternatively, you ask the patient to look up and you place a lens ready to go on, and as the patient looks forward, you place it on. This is needed when you're starting off because you're a little shaky and you don't want to upset the patient seeing something very close. That's why you're trying to give them something else to think about. You can straight off put it on the cornea if you're coordinated enough also. There are slit lamp adjustments that we need to do. That is, a vertical slit beam is used for the superior and inferior angles. Illumination is tilted to one side and the microscope is straight. You need a parallax to see the real 3D version of the angle. And when you come to the 3 and 9, that is where you need to make a few adjustments. You keep the slit beam horizontal. Illumination and microscope are aligned to be straight, but you need to tilt the housing like so that you create a parallax because the beam now comes from below by about 15 degrees. What do you have in mind when you go for any examination? That should be there in your mind before you start. Of course, we are all obsessed with grading in medicine in all aspects, including gonioscopy. But I think the real question we are trying to answer is the angle closed, occludable? How much can potentially open to? That is looking at the angle closure open angle scenario. And then, of course, is this a secondary glaucoma? There are many secondary features which are sitting there. Look for them also before you come up. The first place to start, of course, is the landmarks. The anterior mouse part of the angle that we talk about is the Schwalbe's line. That's the end of the Descemet's membrane. It is identified by following the corneal parallelepiped. This is a line on the epithelium, the line on the endothelium. They come together, and actually the third line then comes around from the trap meshwork and joins up. All three would join up together at the edge of the Descemet's membrane. That is the Schwalbe's line, and behind that is your trap meshwork. It's a granular appearing tissue quite often with variable pigmentation. And if blood has refluxed into the Schlemm's canal, you would see it as pink. Behind the trap meshwork would be where we expect the ciliary body and scleral spur. These are not always identifiable, and these are both broken lines quite often. The scleral spur being a glistening white, very thin line, and behind that, a variable amount of gray ciliary body band may be seen. And of course, after that is the iris. So those are the landmarks we need to identify to go further. And this is the grading that most of India uses. That's Madan Mohan's grading that was from RP Center. You have a set of numbers 0 to 6, but essentially we are looking at an anatomical location. That is what we want. Most of the other gradings talk about a little more vague, and some of them use angle between the iris and the trap meshwork. Those are difficult to talk about, but we can always add a note on occludability saying this angle is wide open, this angle is moderately open, this angle may close easily. For minimum ambiguity, we should ideally be using the posterior most structure seen in that setting. CBB can be a short form for ciliary body, or IATM for anterior trap meshwork. That would be unambiguous for the next person seeing a grading to look at. Next thing is some angles do look close, and you can often see over the peripheral convexity of the iris into the depth of the angle. With the 3 mirror, this is not possible because the diameter of the lens does not allow for any movement of the lens. And how you do that is without any pressure on the globe, you rotate the lens along the curvature of the cornea so that your mirror is tilted in a slightly different fashion so that you see deeper into the angle. So when you want to see the inferior angle, you rotate the lens a little more inferiorly and you see into the depth of the recess. That is, instead of the red arrow, you're going to be seeing the green arrow into the depth of the recess. Now I'll go through one gonioscopy. The first question I said should be, is this occludable? I say the first question because once you get the pupil to constrict, it may stay a little more open. Aim is to see the angle at its narrowest, use dimmest illumination possible for you to visualize, and shorten and thin the beam so that it doesn't hit the pupil. And out here, you almost get all the lines coming together, but there's a gap between here and here. That means it is actually close right now. And when we increase the light a little bit, mind you, this is the same angle. You see a little bit of the trap meshwork out here, and concentrate on this pigment here. And if I allow that to hit the pupil properly, and you see the back edge of the pigment, so now it becomes what is probably grade 3. That is anterior 1/3 of trap meshwork is easily seen, and maybe the middle third. And to go beyond, you need to do what is called indentation. What we do with indentation is, most people think we are forcing aqueous into that angle, but that's not what we are actually doing. We are pressing on the apex of the cornea. This would cause the cornea to rotate out, the limbal ring is stretched, and this would cause the ciliary body to move back and the lens iris diaphragm is pulled back. So net effect is you get it to the maximally open. You can do that with a 2-mirror lens or a single mirror also by doing something like this. It's manipulative gonioscopy as we call it. You ask the patient to keep looking straight and you pull the lens straight down or straight up depending on which angle you're looking. That is, pull the lens towards the angle you are looking at, and that would indent the cornea and you can see the angle open. So when we do that to the same angle that I was showing you, that is a pigment that we are talking about. But out here, you can get it all the way to ciliary body. It's fully open now. No syndicate, nothing. So if you have not been going through this in a stepwise way, you would call the angle open and the patient has got a POAG or NTG depending on the intraocular pressure, needing lifelong medical therapy, etc., etc. But if we go through it step by step and see how narrow it was to start with, all he needs is probably a PI. The same thing can be done with 4-mirror lens. It's easier here, and indentation is just pressing straight back. So you start off with your dim illumination, etc., grade the angle and press the cornea slightly, and you would see it open up. But mind you, if you press too much, you would cause Descemet's folds and you can't see the angle. So you have to be very gentle at the indentation part. It's not just use all your power and press the cornea to open up. Of course, we need to look for other features. Peripheral anterior synecdoche may be there, and we need to classify whether it's the typical closure one or not. Pigmentation has been noted. It comes in significant in certain situations. And any of the features, most of the secondary glaucomas have got features in the angle. So you need to look at that also. And when we record it, you record it as from the minimum seen to the maximum it can open up to in each of the quadrants, and of course any specific finding marked with the clock hour also marked out. Now I will just take you through a few of the gonna pictures that I have. And the synechiae in angle closure can be an appositional closure synechiae, which has got a slight curve, slight variation in the height, but the anterior edge is smooth, as opposed to a creeping synechiae where it is straight up and flat, equal height right through. Inflammatory synechiae would tend to be a little irregular, moth-eaten like this, more often inferiorly, and they need to be differentiated from iris processes, which can be thick like this, and this is what can look like a synechiae. These are just strands of iris going onto the trap meshwork, whereas synechiae are full thickness iris that's plastered onto the trap meshwork. It's pretty easy once you see a few gonoscopies. Plateau iris configuration, when you see the angle, you see the line of the iris, the illumination line just breaks off into the abyss, that's a plateau. And when you indent, you get the sine wave sign, down, and up again. What's supposed to happen is there is a ciliary process sitting out here. So it's down, up again onto the lens curvature. So that's how we identify a plateau iris configuration. If it stays after a peripheral iridotomy, we call it a syndrome. Pigmentation of trap can vary a lot in normal, so I wouldn't give much credence to pigmentation without additional findings like a Krukenberg spindle and a pigmentary glaucoma, pseudo exfoliation. You got supportive findings, and then you call the pigmentation significant. And inferior is usually more pigmented, but the genuine pigmentary glaucoma, the entire angle is going to look like this, and it's like a carpet of pigment. In trauma, you got a lot of findings in the angle. And of course, recession is what we tend to look for typically. You have a irregularly widened ciliary body band and torn iris processes. And you may have other features of trauma sitting there. You may have a black ball-like structure sitting there that's hemosiderin, leftover hyphema, what is left of it, a remnant of a hyphema. Your ciliary body band is irregular in width. And this red arrow, I don't know if you can make out, it's a very faint finding. You have half an iris process sitting on the trap meshwork, the other half has been torn off, which means it's been stretched. So all these put together would be what we call recession, because ciliary body band width also in normals can vary a lot. Always compare with the other eye also when you look for ciliary body band width, because it can differ with patients. Cyclodialysis, this is a little more tricky because it's a soft eye. Doing gonoscopy needs a little experience, so get experience enough to get to this point. That is, you see sclera right through a cleft, and when you indent, I'm sorry, I don't have a video of this, it fish mouths open a little bit, it actually moves. And that you get only one chance because you're starting with pressures of 2, 3, and by the time you indent slightly, it's 0. And next thing you have a flat AC. So you get only one chance to look around, suspect place, indent once, and that's it. In trauma, you can have a small iridodysis sitting in the periphery, which may not be visible with slit lamp directly, but you may pick it up on gonoscopy, as also a tiny hyphema like this would be picked up only with gonoscopy. Neovascularization is another thing that we need to look at very carefully. From this stage to an irretrievable neovascular glaucoma would be just 2 weeks. So we need to pick it up at this stage. Neovascularization of angle is a vessel that's coming on. It's not just crossing across. It has to be branching onto the surface of the trap meshwork, arborization. You have normal thick vessels which may cross, which may penetrate in. Those are very thick vessels. Or you can have loops of veins sitting here. They are not neovascularization. What you're looking for is a capillary network on the trap meshwork. Even a synechiae of a neovascular glaucoma, when you look, the anterior edge would have some vessels there. Even if it has come all the way to cornea, the anterior edge is quite often vascular, and much later, once the ectropia stage comes, that may not be vascular anymore. A failed trabeculectomy, sometimes, quite often, it is a conjunctiva that's a fault. Sometimes you have some tissue sitting here. You have not made a basal iridotomy, you got a loop there, it goes into the ostium and plugs it. It can be found only with gonoscopy. Axonfeld anomaly, you have a posterior embryo toxin that's like a shelf here, a Schwalbe's line that is thick and shelving out with a strand of virus, a bridging syndicate going on to that. And of course, you've got other findings of corectopia, etc. In eyes, there is usually some corneal edema making it a little hazy, but here you've got a pulled up syndicate. This area is very open and sharply pulled up syndicate, which is broad and it's due to a contracting membrane. It's a pulled up syndicate and a pushed in syndicate from behind. And gonioscopy is not only for glaucoma, it is for anything in the peripheral AC. Even a posterior cornea finding may be better seen with a gonioscope. Is that opacity full thickness? It may be very anterior opacity, but you can make out that he needs only a PTK because the posterior 2/3 of the cornea may be clear. And once you get rid of the air cornea interface, actually structures in the AC and iris are seen better. So if you got a SPK or something of that sort, you may be able to examine the anterior chamber better once you put a contact lens in. This is another situation where I had a progressive corneal edema. It was progressing and it was progressing for about 4 years before I got my hands on the patient. And there was a tiny refractile crystal sitting here. And then I get the history that 10 years before he had a corneal tear repaired, and that was a tiny piece of stone. And taking this out, most of the corneal edema disappeared. Of course, our cataract surgeons do give us some surprises like this. This is clearly fixed lens, and the surgeon managed what I have great difficulty in congenital glaucomas with. That is actually to cannulate the lens canal with the haptic. Patient's doing well, so nothing has been done for this. We're just observing the fellow. And sometimes you get findings like this. This is a filmy one, muslin cloth like thing sitting in the angle, probably an organized hypopare is what I suspect it is, but I have no clue what it is. It's a membrane here, patient has no other problems. Not even glaucoma. Thank you.
Dr. Thomas, very well covered.
Thomas, you can come out of the screen. You can start unsharing.
I have done that.
Dr. Thomas George?
Yes.
Very nice presentation. I just have a question for the sake of postgraduates. See, even though you say gonioscopy has to be a part of the comprehensive eye examination, whenever we interview a lot of postgraduates who have even finished their degrees, many of them come with very discouraging numbers. They have done very few gonioscopies during their PG training. Do you know the reason why it happens? And also, can you probably ask, suggest how to get around this problem?
I think the problem is they're not trained under Ravi. Ravi Thomas insisted on 100 gonioscopies before we get further than first year. Anyway, that's the only way to go about it. Do gonioscopies. Actually, you need to do gonioscopies in perfectly normal open angles to get used to the anatomy. Exactly. So that is something that has happened at the PG level. And that's the only way to do the gonioscopy. And only if you're confident of gonioscopy will you actually do it later on in life.
Yeah. And also, many people do gonioscopy only when the AC is shallow. They don't think that probably gonioscopy has to be done in all kinds of glaucoma cases, especially even in POAGs. I mean, normal ACs or deep ACs. I think, as you pointed out, it is first important to see in a pseudophakic patient where the angles are open. They get to see all the things what they are supposed to see. To later, probably they find out what is not being seen. Because most people I've seen, they do gonioscopy only when they suspect an ACG, not in normal routine cases. And any word about surgical gonioscopy for the sake of postgraduates?
Like surgical gonioscopy, it is going to come in a big way because angle surgeries are being done now. We already have goniotomes, the blade, the cahook is coming in. All sorts of angle surgeries are going to come in. Possibly the eye stent. All these are being told to us by the different people. Once you do that, you need to. And the surgical gonioscopy is typically direct gonioscopy. You need to tilt the patient's head about 15 to 20 degrees away from you and the microscope 15 to 20 degrees towards you because it's a slant view that we have. And that's a totally different ball game altogether. And The difference is, what I talked about is a mirrored gonioscopy. The images are laterally inverted. In a surgical gonioscopy, we tend to use the direct because the image is not inverted and it's easier to make our movements out there in the angle where we actually have very little space. And we slip and we make, we'll tear the whole iris off, something that make a descendant detachment. You have very little space and you got to be very controlled.
Thank you.
Very well covered, Dr. Thomas. I have just one or two queries from the public. I am sitting in Delhi in a tertiary level hospital, and my Delhi practitioners get an OCT done, get an anterior segment OCT done, but do not do a gonioscopy. It's not that they are unaware that gonioscopy is so simple to do. It's not that they are unaware that diagnosing angle closure in time and doing a PI in time can save the eye from blindness. It's not that they haven't attended CMEs. It's not that they have looked at lectures like yours. It's not that they have not been trained. What is the reason? I still am at a loss to know why would they get an OCT anterior segment, OCT posterior segment, but not gonioscopy. And believe you me, I've had doctors who were done a PI for because they didn't get a gonioscopy in time and they were told to put latanoprost and all the drugs.
I agree with you, madam. Probably it's cost effectiveness for the management. I have access to anti-segment OCT and UBM, but I'm very uncomfortable interpreting those without actually having done a gonioscopy also. Because gonioscopy is what I'm most comfortable with. Gonioscopy gives you a dynamic view. It is, you can dim the light and you can make the light better.
That's okay. We all know that, sir. I'm just saying, why is the ophthalmologist brethren of ours, why are they so
probably
wary of doing gonioscopy? Why don't they want to do it? We've been talking about this for donkey years. At least I've been 20 years. We've been talking gonioscopy. And OCT has just been around the picture in the last 5-10 years. Why?
Probably OCT, some technician is sitting and doing it. He is probably saving on his time.
Any other suggestions?
Gonioscopy, you got to get your hands dirty.
Any other suggestions? Yes, that's the one, very valid. Anybody else would want to just give, because this is important for training our residents. We have to be convinced ourselves.
Yeah, I think it's a matter of, what training we have gone through. I know what training you have gone through, Thomas George has gone through, I have gone through. And we've all gone through training where right from the day we joined, we've been given a gonioscope and told, look at the angle. And, as Thomas said, Ravi's policy was that the first 100 patients you see, you have to do a gonioscopy on, every single patient. So when you do that, then you lose the fear of gonioscopy. You become very adept at doing it. And with a 4-mirror, it literally takes less than a minute if you're experienced to assess the entire angle. The other thing that's not emphasized is that actually gonioscopy tells you a lot more than just about glaucoma. Because, you see it's very important for glaucoma. You certainly can't diagnose open angle glaucoma without gonioscopy because you have ruled out angle closure. That means you have done a gonioscopy before you have diagnosed open angle glaucoma. But, things like evidence of past trauma, like those little black balls and things like that, that might be the only thing that you see that tells you that this patient has had trauma in the past. And that explains a lot of findings, other findings which you may find in the eye. So, the value of gonioscopy in general diagnosis, the value of gonioscopy in uveitis, in very subtle uveitis, is really not being emphasized in our training. So, it's up to us to kind of keep on emphasizing.
With a very clear signal that he wants to wind up. Just the winding up thing, all of us have to be convinced, and we all sitting here, these 20 people are convinced, we've been trained like that. We have to pass that training on. And more than that, when any patient comes to us without gonioscopy, give that feedback to the doctor there and then that gonioscopy has to be a part and parcel of the glaucoma investigations. He or she cannot do a glaucoma investigation without doing gonioscopy. That feedback constant has to go back. It may be Cochin Club, it may be Delhi Club. That feedback has to go that you cannot get away without doing gonioscopy. So we have to audit that and implement that. And last one, gonioscopy is a dark art. So when you do that gonioscopy, just ensure that the lights are dim in the room, and that's also important. Wonderfully covered. Thank you.
Next, we'll have Dr. Kiran speak to us on optic nerve changes in glaucoma.
Yeah, is it visible now?
Yes, it's visible.
Thank you.
Can you go to full screen mode?
Yeah, I'm just going here. Right. So, slight change in batting order. Sorry for that technical issue I had. So, optic nerve head changes in glaucoma. Am I audible? Can I go ahead?
Yes,
Yes,
sir.
please go ahead.
Okay. So, optic nerve head changes in glaucoma. It's very, very dry topic. If I just start listing all the optic nerve head changes, it's going to be very dry. So let us look at some clinical scenarios. We look at three discs. So the first thing that happens when you have discs like these, we are immediately going to get fixated on this disc at the right edge, simply because you find a relatively large cup disc ratio. But is that the story? Not really. You see, if you look at it anatomically, all these three discs will individually have around 1.2 million axons that will be coming out through the neuroretinal rim and going back. But these 1.2 million axons, give or take a few between these discs, will have to come out relative to the size of the disc. So what you will generally find is when you have a larger size disc, right, the ones which you find on the right edge of the screen, you will find their cup tends to be simply larger, even though they are completely healthy. So our natural tendency when we see a disc like this, because of the large cup disc ratio and our fixation on the cup disc ratio, is immediately label this disc as a suspicious optic nerve head or a disc suspect or a glaucoma suspect, and then go on investigating. But as I said, the problem in glaucoma is not really at the cup. The cup is simply a proxy to where the actual problem lies. The problem lies in the axons of the ganglion cells. So we are actually we need to look basically at the neuroretinal rim and the borders and the retinal nerve fiber layer. So that is the first and the foremost part about examining an optic nerve head. So what are the basic fallacies of the cup disc ratio? As I said, these are three discs with three different disc sizes. So the important thing to note is you can have large discs which have large cups in healthy eyes, and small discs generally have small cups in healthy eyes. So even small discs with glaucoma, as you can see here, may actually have small cups. So the first and the foremost idea that has to come into our mind is to start looking not at the cup itself, but at the rim and the borders right here. Now, about 10-15 years back, there was this wonderful article published by Dr. George Spaeth, when he looked at a series of discs. You can see that these are very scary looking discs, A and B. A and B seems to have very large cups, very scary looking cups. But interestingly, not A and B, the ones on the top. These are discs which he has followed up for many years, more than 10 years, and found that they actually do not have any glaucoma. The smaller discs here, which you see at the bottom of the screen, are the ones which actually turn out to have glaucoma. So they looked at it very objectively and found that a large cup disc ratio has actually got a very low correlation, as I have marked here, a very low correlation with glaucoma. And this is an important point. In fact, they found that in the diagnosis of glaucoma, it is narrowing of the rim that has the highest correlation with the diagnosis of glaucoma. And in fact, even as a sign of worsening, it is progressive narrowing of the rim and disc hemorrhage, which has a moderate correlation, right? So, and he came out with this disc damage likelihood scale, which is a very objective way of actually looking at the optic disc in terms of its size. So you can have a small, average, or a large size disc depending on the size of the diameter of the disc. Less than 1.5 millimeters is the small disc, and greater than 2 millimeters is the large disc. How do you measure the size of the disc is something I think we can probably come out in the discussion part. And this is an objective scale all of us can use very simply. It will hardly take about 30 seconds to actually label a disc and stage it. And the interesting thing is, it is not simply a method of actually staging a disc. This is simply on the basis of disc appearance, on the size and the rim changes. He actually compared it with the HRT and the automated perimetry and found that one, it was superior to the cup disc ratio, and it was as sensitive and specific as the HRT2. But this was published in 2006. This was a time when people were all gung-ho about HRT and GDX, and Stratus OCT was coming up in a big way, and we had all kinds of articles which were looking at those in machines, and this was basically comparing the disc damage likelihood scale and found that it was as sensitive and specific as all the fancy machines. Now, the second thing is to look at the retinal nerve fiber layer, and this takes a bit of practice, and it's easier to examine in the red-free. In fact, the diffuse nerve fiber loss is something that is very difficult to distinguish initially. It is the localized nerve fiber loss, which on the red-free can be is something that you can develop as a skill, and it's an important skill. And it's an important skill. You can see these the nerve fiber layer defects. The important thing about the retinal nerve fiber layer defects, localized defects, is that they are highly specific for glaucoma, right? And they are generally found, in early glaucomas, you are able to pick it up very well, and they have a slight preferential location in the superior and inferior temporal regions, and generally they have stronger association with the lower pressure glaucomas and disc hemorrhages. For example, in the normal tension glaucoma here, you can find that they tend to be slightly wider, as you can see here, and they tend to be closer to the fovea in the POAG. But this is a distinction that you can simply make. It's not a sign of diagnosing an NTG, but it's something that you sometimes find. Interestingly, these are two examples of two discs where you have clearly well-defined RNFL defects, right? It is well-defined on both the eyes. The Stratus OCT actually is not able to pick it up, right? So this shows how sensitive the examination of an RNFL defect is. You are able to pick it up on red-free and on slit lamp examination, but even a fancier machine like the Stratus OCT is not able to pick it up. Obviously, the Cyrus and the modern versions of the machine might be able to do that, but this is just an example to show you how good examination can actually be very useful in diagnosing early glaucomas. A few words then on the other important aspect of an optic nerve head change in glaucoma, which is the disc hemorrhages. So you can find these flame-shaped hemorrhages. You have to really look for them, because one of the problems with these optic disc hemorrhages is that they can be transient. So they can be present on one of your examinations, and a month later they might not be present there. And the other thing is, as I mentioned, it requires very careful optic disc examination. I think in multiple trials it has been shown that if you don't actually take disc photographs and examine very, very carefully, you might actually miss optic disc hemorrhages even with glaucoma specialists. So this requires a reasonable, careful examination. Example, these hemorrhages are very difficult to see if you are not able to look very, very clearly. And importance on the appearance and disappearance of optic disc hemorrhages. You can see these pictures A, B, C, and D of the same patient from 2007 July to 2008 March. You can find that in 2008 January, you have the appearance of a disc hemorrhage here. And the next month it is actually increased in size, and by the next month it has disappeared. But by the time it's disappeared, it has actually caused further damage to the neuroretinal rim, and the visual fields have progressed in the meantime. This is the importance of recognizing optic disc hemorrhages. They are an indication that your glaucoma treatment is not optimal and is actually worsening. Other examples of optic nerve head changes where you can actually end up in a lot of difficulties, high myopia, when you have these kind of large beta zone changes and tilted discs where you are unable to clearly delineate the borders of the disc. When you do a visual field, you find that you have these changes and you are tempted to start into treatment, but 5 years later, nothing has changed even without treatment. So with myopia and optic nerve head analysis and in glaucoma, usually there is a problem because there are a lot of population studies which show an increased risk of glaucoma in myopia, but the OHTS did not show any association. And a couple of other studies also did not really show any association with glaucoma. One of the reasons why this happens is, as I said earlier, these are very difficult discs to assess. It is very difficult to delineate the borders. It is very, they generally sometimes have very shallow cups, and it's very difficult unless you get a good stereoscopic view. And they generally, because of the nature of the myopia itself, tend to have very thin RNFL and RNFL defects. Another example. So you have two optic discs here, both of them showing superior RNFL thinning, right? But again, this patient has, normal acuity, normal intraocular pressure and everything. But because you see a superior optic nerve thinning, it is bilaterally symmetrical. You have to be aware of conditions which are not glaucomatous, like superior segment optic hypoplasia, or SSOH. So these are situations which are developmental in nature and tend to occur bilaterally symmetrically. And when you do the visual fields, you will find these defects and you'll be tempted to start treatment, but 4 years later, again, nothing has changed. The only problem is, once you are very happy after giving a fancy diagnosis of superior segment optic hypoplasia, the problem is there could be pre-existing, there could be a superimposing glaucoma that can develop, right? For example, in a superior segment optic hypoplasia, you can see here, you have these disc hemorrhages that also occurred. And once the disc hemorrhages have occurred, you can find that the visual fields have also started worsening, and the central area of the visual fields, which was unaffected in 2003, started getting affected in 2007. So even if you find that these cases where the discs are kind of what you label as anomalous or a superior segment optic hypoplasia, and you still need to continue to follow them up because they may have superimposed glaucoma that develops on them later. So, of course, these are discs which look very much like glaucoma. There might be ancillary investigations to help you to diagnose these conditions other than simply observing the optic disc. But we need to be aware of these conditions like optic nerve colobomas and morning glory syndromes and optic nerve pits. So these are conditions which we have to basically aware of, and obviously there are ancillary investigations to diagnose these congenital optic disc anomalies. So a couple of messages. One is, you see a disc like this with -10 and -8 diopters respectively, and these are discs which appear highly glaucomatous to a lot of eyes, and you do a visual field like this and you find these defects. What you need to understand is these changes, what you have seen in the optic nerve head and the changes you see in the visual fields, which are the two basic things we do, can actually simply because of the myopia itself. And they may be simply because of the optic nerve head changes that are already present in myopia. And when you see a field like this, and we do not need to jump the gun and start treatment, you can simply observe them. Now, on the other hand, you see a disc like this, all right? You look at the examination disc very carefully. As I said, forget about the optic cup disc ratio. You start observing the neuroretinal rim, all right? And as you can clearly see, there is an RNFL defect here. Which I have marked in arrow, and there is another arrow which I have marked here, which is showing a optic disc hemorrhage. All right. So in this situation, as I said, it is possible that if you were doing a stratus OCT, you might actually even miss the RNFL changes, but you have actually seen it on this optic disc. You have seen the hemorrhage. So when you do the visual fields, you can see that there is probably a developing nasal step, but you are very well justified in starting treatment on this patient because you have been able to diagnose an RNFL defect and an optic disc hemorrhage in this patient. And even though the fields are not very conclusive and you are not having access to a lot of fancy equipments, the conscientiousness of your optic disc examination will help you to start treatment on this particular patient. Thank you.
Thank you, Kiran. Very elaborate and very lucid. I think probably the most important in the postgraduates and young ophthalmologists have to know how to evaluate a disc. I think there are a lot of investigations available, which can sometimes we end up getting confused. I think looking at the disc probably is more important than looking at the IOP, can be sometimes elusive. But in the disc is something which is probably very, very objective, and probably it's like moving from effect to the cause than the cause to the effect. Very well put. And any particular advice to the postgraduates how to master this art of reading the disc? Like always should you dilate a patient, or can you still see the disc in an undilated pupil?
You can see the disc, but again, it depends on your training. As I said, when we were in the RP center, it was mandatory to do 90-day examination from the very beginning on all patients. Initially, we all examined patients under dilation, right? Under dilation, this helps you to kind of master the 90D. One of the simplest tricks that you need to learn is to examine with the 90D, because the initial tendency, at least in those days, were to use the direct ophthalmoscope, and it was considered sacrilege to use a direct ophthalmoscope inside the glaucoma clinic during that time. So only once we learn the art of examining the 90D in dilated pupil, it becomes easier in the undilated pupil. In the undilated pupil, it is not always possible to have a stereoscopic view, always, all the time. That may not be completely possible, but yeah, the biggest thing is that even with the electronic medical records, you find that most of them have actually cues for putting the cup disc ratios, and this is something that we kind of get fixated with, you know. So rather than putting the cup disc ratio, we should rather put down the size of the disc, look maybe the rim disc ratio, and look at those focal changes more importantly, and that kind of will help us in actually, you know, diagnosing glaucoma better.
I think it's just not in glaucoma clinic now. Direct ophthalmoscopy is out of the window now. Anyway, for anything you can't use it now. So I think you said it very right. I think it's very important for youngsters to know that the size of the disc, because that can be the thing. Because you may think that it's a large CD ratio. In a very big disc, it doesn't really matter. At the same time, looking at the focal damage rather than the CD ratio, where everybody talks about CD ratio, I think that is probably has a lesser importance. And it was very well told about the DDLS, which we have not really incorporated much into our practices. I think it's a very useful Dr. Spade's work on DDLS. I think it's extremely, practical to get into that.
Yes, yes.
Thank you very much.
The key is that
would be that at least once we should have a dilated exam for the patient, because quite often it does give you a different perspective. Undilated, we are quite often not seeing the entire disc and NFL in one shot. So at least once we should have dilated the patient. And for the routine, we don't want to trouble the patient too much with dilatation. Undilated would be enough. But whenever possible, dilated preferred.
Absolutely. The thing is, the first identifying a person as a suspect through the disc examination, that may not be possible in the first sitting simply by dilating. But once you have identified a person as a disc suspect and he can be dilated safely, or you have to at one point of time do a PI and then dilate. But of course, once you make that initial diagnosis, it has to be under dilation, because you cannot really look at the retinal nerve fiber layer without actually a good dilated examination.
Can I just ask one question to Dr. Kiran? We've talked about, we've all agreed that stereoscopic disc examination is what's needed, and preferably at the slit lamp using one of these lenses. So which lens would you say somebody who doesn't have a lens right now should buy? A 90D, a 60D, or a 78D?
Yeah, I have experienced both the 90D and the 78D. I'm just more comfortable with the 90D. That's all. I have no idea why one would prefer the 78D over the 90D or the 90D over the 78D. But
well, I have some idea. I generally prefer the 78D. And actually, if you look at the compromise between magnification and field of view, the 78D has more magnification than the 90D, which helps you in your examination of the posterior polar structures. The 78D also, very little known, but this is absolutely true, and it's given in the Vogue catalog, has more of a field of view than the 90D. So
I agree with you, Andrew. I started using 78 diopters only last 2 years, and I just wondered why I didn't discover it before, because it gives you such a beautiful stereoscopic view vis-a-vis 90D, and the field of view is pretty okay for a glaucoma person. So I agree with Andrew that it's 78 diopters is much better.
It's a force of habit. I think whatever you have, you can use it, but use it. Okay. If you have a
yes,
choice, go for 78.
Yes, yeah, that's.
Sir, what about increasing the magnification on the slit lamp eyepiece?
Yes, you can. Yes, definitely. So, but using your slit lamp, the Hargstrite usually has a basic 10x magnification. Without having to change the magnification, you get a pretty decent magnification with the 78D, and it just forms a routine part of your examination. But yeah, you can adjust the slit lamp magnification.
Being a retinal surgeon, I would also want to tell the glaucoma people that, sometimes an old branch retinal venous occlusion in the periphery can also lead to an RNFL loss in that place. Without a proper, good, dilated examination of also the periphery, one might be forced to think that this is glaucoma or something like that. So again, another reason why we should at least dilate and see.
Yeah.
Okay.
Can you go to the next talk?
Yeah, I want to tell that we have only 15 or 16 people in this Zoom meeting, basically because we have only incorporated the moderators and the speakers. All the rest are, viewing in YouTube, and there are about 250 people viewing right now. Live.
Okay.
Yeah. So can we have the third talk?
That would be me. So I think I am supposed to talk on visual fields. So okay, is that visible?
Yes, sir.
Yes, it's visible. Go ahead.
Okay. So basically, I am talking about visual fields in glaucoma. And visual fields is an old topic, but it's specifically automated perimetry, not the Goldman visual fields. So I always start this with very, very basic definition. And that's the visual field is defined for the individual eye as that volume of space that is simultaneously visible to the steadily fixating eye. And these words are very carefully chosen. So if you look at it and try and understand the words, it means you look straight ahead, and whatever you can see in the periphery, that is your visual field. And it's not an area, it's a volume. It's a volume of space. Okay, so the classic analogy is trachea's island hill of vision, and this is my very diagrammatic representation. A better diagrammatic representation is what's given in most of the textbooks, and this is more or less, it correlates with the intensity of the stimulus that is visible, etc. The highest point is the most sensitive, so it can see the dimmest light. And when you go down to sea level, that's black, it's darkness. So it's the island hill of vision in the sea of darkness. And this analogy is very, very apt, and we will keep going back to it. Now, if you look at a scotoma, apart from the blind spot, which is a deep well that goes straight down to sea level and is an absolute scotoma, all other scotomas that we see, except in the very late stages of whatever disease, are all relative scotomas. So we have lost a little bit of the real estate that we have in our hill of vision. And that's never coming back. And that's really the most precious real estate we are ever likely to own in our lives. So what are the techniques of trying to plot this hill of vision? There are two, kinetic and static. And in kinetic perimetry, you basically, let's say that we are observing from above where that black arrow is, and that we fly in several jets from various directions at a particular height above sea level and make them crash into the hill of vision. And where they crash, we mark a dot. And when we have a ring of dots, we join it in a circle, which is the isopter that we classically see in kinetic perimetry. The disadvantage of this is that if your particular jet is not flying at the correct height, and you can see that from these arrows, if one is here and one is here, you're going to miss this excavation. So you may miss localized scotomas. It also has the assumption that all points on the isopter and within the isopter have equal or greater sensitivity than the isopter, which may be completely wrong. Now in static perimetry, let's consider that we are again observing from above there, and now we have these helicopters hovering above the island of vision, and we send down paratroopers, and wherever they land, they have a little meter with them which tells them their height above sea level. and they report that to us. So now what we are doing is just plotting numbers in a particular location, and therefore it makes no assumptions. We are only reporting what we actually find. And because we are spreading this pattern around in the area where we are likely to pick up problems, we are more likely to pick up subtle contour defects. And what we are looking for in perimetry is small early contour defects. So that's the advantage of static versus kinetic. Make no mistake, static automated perimetry is now the gold standard for diagnosis and management of glaucoma. Nothing less will do. So what are the strategies that you have in static perimetry? Now, there is a so-called supra-threshold or screening strategy. There's a threshold-related screening strategy, and there's the full threshold strategy. What do they mean? Now, if you take a supra-threshold strategy, it just tests at a particular level, and there's either a yes or no response. So if there happens to be a scotoma at that particular point that you're testing, which is picked up, well and good, but it would require a fairly advanced defect for you to pick it up. You can make this a little more sensitive by doing a threshold-related screening. That is, you vary the threshold depending on which part of the field you're testing. So when you're testing very near the very sensitive center, you use a dimmer stimulus. When you're testing in the periphery, you use a brighter stimulus, and that will pick up some of the contour defects, but it may also miss a subtle or shallow contour defect. The full threshold strategy is the only one which can actually accurately map the contour of the hill of vision, and the only way that we can pick up early shallow scotomas. This is the gold standard for diagnosis and management. I've been saying threshold, threshold, threshold. What is threshold? So if you take a frequency of seeing curve, that is, if you shine a dim light, okay, and slowly increase the intensity. At one stage, you'll have the light so dim that no one can see it, or that you don't see it at all. Then when you slowly increase the intensity, you then reach a stage where you can sometimes see the light and sometimes not see the light, until it reaches an intensity where you can see the light all the time. Now, that in-between area, okay, is what we are interested in. And where you can see the light 50% of the time, that is defined as the threshold for that particular point. What units do we use to measure this intensity of threshold? Now, light is measured in apostils, but unfortunately, it's a logarithmic increase. Our sensitivity to light is not a linear scale, but a geometric scale. If we want to convert this geometric into something linear, then we have to use a scale which, like the decibel, which has actually no units, but is just a number that gives us a corresponding value. You can set the zero anywhere and increase in fact for visual fields, because we are interested in having a higher number, the more sensitive the point is. We actually turn it upside down so that the brightest stimulus is near the zero of the decibels, and the dimmest stimulus is a higher number in decibels. This helps us to just think in a linear manner that if the sensitivity of a point is near zero, it needs a very bright light for the person to see anything. If the sensitivity is high up in the 20s or 30s, it needs a dimmer light. How do we actually determine this threshold? And this is where this perimeter is very clever, and this is where we can use the computer to great advantage. Let's say you start off with a stimulus that can't be seen, and there's a negative response. The patient doesn't respond. That stimulus is increased by 4 decibels. You get another negative response. You increase it by 4 decibels, and now you get a positive response. That means that you have crossed the threshold. In the older perimeters, it used to be then decreased in steps of 2 decibels until again you get the negative response. And then that average between the positive and negative is taken as the threshold value for that point. And similarly, if you start off with an initial positive response, you reduce in increments of minus 4 decibels, and then you cross the threshold, go back again and cross the threshold. Now, this double crossing of the threshold is a little more time consuming, and that has been dispensed with in the newer test algorithms. So only a single crossing of threshold is done. But this is basically how it's done, a bracketing strategy. How do we test whether the patient has performed reliably during the test? So in the Humphreys field analyzer, which is the machine which I'm most familiar with and therefore will be talking about the most, you have what is called the Heil-Krakow strategy. You shine a light in an area which is not supposed to be sensitive to light at all, and that is classically the blind spot. And the blind spot, the position of the blind spot is pretty fixed. So you shine a light where you expect no response. And if you get a response, obviously the patient is not looking in the correct direction, and that is marked as a fixation loss. False positive, false negative responses are obvious if a previously tested area has a particular level of stimulus and you shine a dimmer light in that area, but you get a response, then that's a false positive response. A false negative is when you have a dim area where there's a particular sensitivity and you shine a brighter light, which should be seen, and you don't get a response, that's a false negative. Now, false positives are almost always due to inattention or some error on the patient's part. False negative responses can be due to wide fluctuations, particularly at the borders of a very steep-sided scotoma. Also, because of microsaccades, one stimulus may land up deep in the scotoma and one stimulus may land up more superficial in the scotoma because the sides of the scotoma are very steep. So they could be normal at the edge of a steep scotoma. Gaze tracking and head position are also important, and you can possibly dispense with fixation losses testing by the Heil-Krakow strategy if you are carefully monitoring the eye position during the test. And this is what the octopus perimeter does. By monitoring the eye position, it will just not present a stimulus when the eye is not fixating correctly. So that eliminates one of these tedious reliability criteria. The next question we need to know is what is norm? And this is where we need to be familiar with this bell-shaped curve, which is the Gaussian distribution in statistics. And everything in perimetry is based on statistics, and we cannot escape knowing this definition. It's simple. Any biological parameter, whether it is the blood pressure, whether it is your pulse rate, whether it is the threshold at a particular point in a set of individuals, will have a particular distribution like this, and it will be distributed across in a bell-shaped manner, with the center of the bell, the highest point, being the mean. 2 standard deviations away from the mean will enclose 95% of the values. 3 standard deviations away will enclose 99% of the values. And we use this to define normal. So actually, normal is defined in the context of the chance of something being abnormal. All the data that was recorded in that bell-shaped curve is recorded from normal individuals. And yet, by our definition, we are labeling either 2.5 or 3% or 1% of them as abnormal, or 5% of them as abnormal. So it's important to understand this because we have to accept or not accept our statistical definitions or statistical labeling based on additional points in the clinical picture. Otherwise, we might be wrongly labeling a patient. Then there's another concept involved in this threshold. Normal points can vary by 1 to 2 decibels during a single test. The threshold can vary. They can vary over longer periods of time too. So that's long-term and short-term fluctuations. Abnormal points will also vary. And when the points are already depressed, they have a larger amplitude of fluctuations. This is important when we are trying to assess progression, and we come to that later. Okay, so let's have a look at the printout. You have this is the Humphreys printout. So you have this very impressive looking, complicated looking analysis here. And we have to go about looking at the printout stepwise. So the first thing to do is look at the patient at the test data. Confirm that the patient is the one that you are sitting in front of you. The name is recorded correctly. It is the test of the correct patient. Look at the vision and the pupillary diameter. So visual acuity has not been recorded here. It should be. Generally, you'll have your technician recording the refractive correction, and they usually write it down there, that has been used during that test. And you also check the other test parameters. Is it stimulus 3? Is it white? What is the test strategy? This is a CETA fast test. Then you look at the reliability criteria. So the CATCH trials are all self-explanatory, and using the blind spot, that's a high-factor strategy. It has 6 out of 11 fixation losses. There's some false positive, false negative errors. If the number of fixation losses is significant, the machine would generally flag it for you, will put a couple of X's over there and say, don't rely on this test because this patient has not been reliable. It's important to have the foveal threshold on because it checks the internal validity of the visual acuity. In this patient, you would have noticed that neither the visual acuity nor the foveal threshold have been recorded in the test. And this is not something that one should usually do. Make sure your technicians do this. This is a test which was done by one of my technicians in England. The gray scale is the next thing we look at. And the gray scale is very deceptive. It has really no value as far as I'm concerned. So I haven't even shown a picture of it. Just glance at it and move on. The next plot that we look at is the mean defect plot. This plots the deviation from the expected values and gives probability symbols. So here you have that in these areas, minus is 13 decibels less than what is expected. This is 4 or 5 decibels less than what is expected. And each of these is represented by a probability symbol. So this is the chance of this spot being normal is less than 0.5%. This means that the chance of that spot being normal is less than 5%. So the blacker it is, the more likely it is to be an abnormal point. The pattern defect tries to correct when you have a generalized depression and you're trying to pick out a pattern deviation on top of that generalized depression. So what it does is it takes the 7th highest defective value and resets the 0 to this point. And this compensates for very common conditions like cataract, which would generally reduce the. If you want to look at it in terms of the hill of vision, if you're trying to interpret things with this as the expected contour of the hill of vision, then you might, everything would appear abnormal because your actual contour now has gone down to this. However, if you look at this, you may still miss some shallow scotomas. The global indices are indices which have been derived from all the data collected in the test and averaged out. And this is compared to a database of normals. So here you have a mean defect of -4. And that gives you a probability of this being normal of less than 1% of this being normal. And the pattern standard deviation is based on the pattern defect. And it's again a very powerful tool to determine whether that field is normal or abnormal. There's an additional test in the Humphreys, which is called the Glaucoma heavy field test, and it compares points above and below the horizontal meridian and a mirror image points, and gives you 5 results: normal, outside normal limits, borderline, or things which cannot be interpreted, like generalized depression or abnormal sensitivities. So outside normal limits or borderline is what we would pay attention to when we look at the GHD. And finally, always look at the raw data. You need to look at specific points to confirm areas of depression. Look for abnormal sensitivities that may have been missed by the catch trials. Now, this test looks pretty normal, but all the points clustered around the center, okay, are 27, 30, and things like that. But we have a couple of 31s, which are fairly far away from the fovea. And the fovea itself, we have not tested this test. This is the same test I showed you earlier. The foveal sensitivity has to be, the fovea has to be the most sensitive point in the visual field. And if you're getting points in the periphery, which are showing more sensitivity than the fovea, either there's something wrong with the fovea or there's something wrong with your test. How do we interpret this for diagnosis? So we have Anderson's criteria, where you look for a cluster of 3 or more non-edge points in the arcuate area, which are depressed to at least a 5% probability, which means they have to be non-edge points, they have to be a cluster, they have to be all adjacent to each other, and they have to be depressed to at least 5%, and one of them has to be depressed to at least at the 1% or less level. You also need to have a PSD, which is depressed to at least the 5% and an abnormal glaucoma hemifield test. So if all these 3 criteria are present, you are pretty sure that you are dealing with glaucoma. If you want to be very sensitive and not miss out any glaucomas, you can say, okay, when 2 criteria are present, I will treat this patient as glaucoma. If you want to be very specific and say, no, I don't want to overtreat, then you will insist on all 3 criteria present before you start treatment for glaucoma. It helps to actually divide the field into zones and consciously look at each zone. So I've gone through all these zones without actually naming them, but these are the ones, the patient name and the data of the test, then the catch trials, grayscale, which you look at quickly and ignore after that, then the mean, the total deviation, the pattern deviation, the global indices, the glaucoma hemifield test, and finally the raw data. So always go through the field in this order, and once you get used to it, you'll really be able to scan through it pretty fast and look for anything that's abnormal. So here we have fairly classical thing, which is by Anderson's criteria. It does show glaucoma. It's a reliable field. You can see that none of the catch trials have been flagged. The grayscale shows a very impressive superior arcuate. The pattern deviation and the mean deviation both show superior arcuate and a bit of an inferior arcuate as well. And the glaucoma hemifield test is outside normal limits. And that's the disc with the very, very prominent notch there, which may not be a great photograph, but you can actually see gross thinning of the nerve fiber layer. And that's the structure correlating with the function to show us a classical glaucoma. You have another test like this, which again is showing us what should be a classical glaucoma. It's a dilated patient, so they put a near correction. There is really no fixation loss or anything else. And we would say, just looking at the field alone, that this is glaucoma. But if you look at the disc, you have a reason for that field effect to be there. And this is probably a static field effect which has been there throughout the patient's life. So you never interpret in isolation. Then a few other common errors that you come across. Now, this is one place where you do look at the grayscale. And why do you look at the grayscale? Because the grayscale is full of white squadrons. Here you see in the pattern deviation, there's nothing in the total deviation. In the pattern deviation, you have a massive number of points which are abnormal. So you think that this is very advanced glaucoma. But if you look at the grayscale, it's got what are called white scotomes, areas which are so sensitive that they have been shown as white. And you look at the numbers, the fovea is 34 decibels. But here, right in the periphery, the patient has 48, 40, 48, 49 decibels visual sensitivity. And the reason for that is that this is a child who's just been happily pressing the button. And if we're not careful about looking carefully at everything in the field, we can sometimes mistake this for an abnormal field. So here, where you have, this is tried to take the seventh highest point. And the seventh highest point, when your highest point is 49, will make even the fovea abnormal. So when that corrects, then you get this bizarre looking pattern deviation. Then again, you have mysteries like this one, where this patient has a pretty normal looking disc, but has this field defect. Again, this is the other eye of the same patient. Now, one would be tempted to think that maybe his eyelid is drooping or something like that. We looked for that. We ruled that out. He's a 59-year-old male, and the field was done because his intraocular pressure was 24. And there was nothing else to indicate glaucoma. So now, do we diagnose glaucoma just because he's got this field defect? No, I didn't. And this patient is still under observation. He still has the same field effects, still the same field with no progression, no change, and his pressure still remains in the very low 20s. So we would say he's a low-risk ocular hypertensive and leave it at that. The next step in visual field assessment is in assessing progression, and this is something that's extremely difficult. So once again, a reminder to you, again, we use a lot of statistics. So remember this bell-shaped curve, remember the definition of normal, and then look at what you need to establish progression. So very simple. If you think about it logically, something is progressing if the depressed point gets further depressed, if a normal point becomes abnormal, and all changes must be more than what's expected based on short-term and long-term fluctuations for that point. You also need to remember that depressed points fluctuate more than that. Now, we don't have to actually put fields side by side and look at them. And we've got some convenient things which our computer does for us in our automated perimeter. And these are the overview printout, the change analysis printout, the glaucoma progression analysis, which is the more modern development, the visual field index, and then something called the guided progression analysis, which actually seeks to combine structural and functional aspects of damage. So an overview printout is the simplest longitudinal record, and what it does is it just prints all the relevant plots of the field all on one page, so you can scan it quickly without having to flip through several pages. So that gives you a good overall idea. So here we have the grayscale, the numeric data, the total and the pattern deviation, with a few other things like the foveal thresholds and the reliability criteria and all that written down below. And you can scan through quickly, and you will see that the total deviation is increasing in this patient over time, with some increase in the pattern deviation, and there you see more and more increase in the total deviation. And it's remaining about the same after a particular stage. Now, this was a patient with actually a neurological problem, not glaucoma. So when we found that the fields were remaining same over 14 or 15 years after an initial change, then we just have to move on. The next is the change analysis printout. This has a very useful plots. The box plot is one of my favorites. Here you have these boxes which are sort of floating around below a particular line, which is supposed to be the zero level normal. And you also have plots of the mean deviation, the short-term and the long-term fluctuations, pattern standard deviation, and things like that. A box plot is it plots the deviation from the expected with the center of the box as the central line as the median value. And the box consists of the 15th to the 85th percentile. The little things sticking out from the box are the 0th and the 100th percentile. That's the total range. Now, ideally, the box plots all should remain at the same level. The median should be centered in the box, something like this here, and the outliers should be equal distance from the from the central box. If a field is deteriorating, you'll find that these outliers will sort of become longer and longer, and this box keeps sinking down, 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 and seems to be just hanging on to that line by one outlier. But that's not the case in this patient, where it has remained fairly consistently at the same level. The short-term fluctuations, mean deviation, there used to be a corrected standard deviation, which is no longer there, but the PSD is still there. And all these should show a downward trend if the field is progressing. This becomes more sophisticated when we go to the glaucoma progression analysis, because what we'd really like to do is to compare each point that we think is progressing to a database of stable glaucomas. And that's exactly what the GPA 1 and 2 do. They compare to a database of stable glaucomas over a short period, and the fluctuations have been calculated so that you know what the fluctuations are in a short period, and it compares each specific point to the data in the database, takes into account the amount of depression of that point at the time of the test, and it assigns a probability value to whatever change you see. So before you do anything else, you need to define two fields as the baseline fields. And this is what we've done here. And here we have the follow-up tests. So you need at least 3 fields before you start using this. The 2 for the baseline, and then at least 1 more. So it helps if you have several fields over time. And the probability of change is given by these black triangles. These little triangles, the blacker they are, the more likelihood there is of that change being actual, being true. Okay. So now here you have something which shows a lot of black triangles, and then suddenly these black triangles clear up, and that's because this test was unreliable. When the test was repeated, it didn't show up again, and that has remained reasonably stable over time. The black triangles have come from the periphery, not showing up too much in the pattern deviation, but still there. So we correlate with the rest of the clinical picture and decide whether any further intervention is needed or not. I think in this patient, we increased the medications, and then the number of black triangles remained the same. This is another example. Again, you can see a few changes. And here, all this was due to basic fluctuations in the field, where the actual amount of change was not of very high significance. The significance could not really be plotted, and therefore we ignored this. The newer tests, okay, show the similar kind of thing. This is and also give you a visual field index plot. So it gives you a deterioration of the visual field index over time, if there is, as well as all these black triangles. Now here you found a large number of black triangles which have vanished. They vanished because all this was due to a generalized depression due to cataract, which finally vanished and became almost back to the original field when the cataract surgery was done. The visual field index is a fairly good index, which is associated with GPA2, and it's based on pattern deviation probability maps, age adjusted and expressed as a percentage of norm. The trend analysis of the BFI, which is given in the GPA2, okay, will help us to show overall trend of progression. How it works, I don't really understand, because all this goes now into the realm of P2C2E, which is processes too complicated to explain, but it's been clinically evaluated and it's a good test. How do we actually know whether any of these tests of progression are useful to us clinically or not? If you want to evaluate any clinical test, you need to have, first of all, a gold standard. You need to perform the test that you are trying out and the gold standard evaluation, calculate the sensitivity and specificity of the new test. And if you have a high sensitivity and many false positives, then it's likely that your new test is better than the gold standard. Unfortunately, there is no gold standard or no single test or observation as a gold standard for glaucoma progression. It's the entire clinical picture, including age, associated disease, IOP control, physical appearance, and features, which we put together and then decide whether that glaucoma is progressing. So you can't diagnose progression simply on the basis of the visual fields or any single parameter in glaucoma. And this is where we need to have a word about event versus trend analysis. Now, when you talk about GPA 1 and 2, and they are doing point-wise comparisons, they are looking at single events at each point. Okay. When you look at the linear regression of the mean defect and the BFI, which is also plotted in GPA 2, you're looking at an averaging of defects over the entire field. Now, obviously, the point-wise comparisons are going to be much more sensitive, particularly if you have a smaller number of fields. And the trend analysis, which is the BFI and the linear regression of mean defect, will be better for assessing progression when you have a large number of fields. However, one thing you do need to understand is that focal progression in a small area, less than 3 points.
To Braganza, can
yes.
you conclude if you don't mind?
Yeah, sure.
Because we have overshot the time.
Okay, so what do? We keep on doing fields because it's important to have enough data, and yeah, message is conveyed. So okay, over to you, KP.
So, Gopal, can I just give some PG related questions regarding fields if PGs are watching?
Sure, madam. Sure.
Yeah. So,
PGs are watching.
Yeah, Andrew, very well presented and very basics you've explained in detail. What happens to PGs is in the exam oriented, you are just asked to read the field. But you have to, if you understand the concepts, obviously you can read it better. So as Andrew said very clearly that grayscale, look at last and talk about it at last. Look at the reliability pattern and now it is 20% for all, less than 20%, and some new database is saying 16%. So reliability, you will be asked questions on that. You will be asked questions on typical field patterns, which are the Goldman patterns of double arcuate or Jerome scotoma, and the static patterns of cloverleaf pattern and white on white perimetry and excessive white, which is false positives. Always say whenever you ask the diagnosis on the fields that number one, I will have to correlate clinically as told so beautifully by Andrew. Second, you need two consecutive, comparable, reliable fields. Consecutive always, not on the same day. Both should be reliable and they should have a similar pattern tendency. Supposing you have one field with an arcuate defect and one field with a nasal step, obviously you cannot make it, even though they're two consecutive and reliable, they cannot give you a diagnosis. And last but not the least, when you are doing the fields, it's very often to save time, you have to explain to the patient that some stimuli will be too bright to be seen. That will prevent your false positives from happening. And again, as gonioscopy, for visual field also, you must have a patient who is dark adapted. These are the usual Viva questions asked. Thank you.
Thank you very much, ma'am.
I think it's over to Dr. P. Satyan from Satyan Eye Care, Coimbatore, on his talk on OCT and its interpretation. We have Dr. Satyan here.
Yeah.
Yeah. Please
Very
go
good
ahead, sir.
to all the viewers, and it is my duty to thank and appreciate the Cochin Ophthalmic Association for doing this wonderful webinar on glaucoma and as well as on other subspecialties.
Sir, you can click outside and then come inside. Yeah.
So I'm just going to talk about the dead cells in glaucoma and how you can really assess the dead cells. When Dr. Gopal told me there are going to be PGs and the practitioners, I was a little confused on how do we really go about talking the OCT. So many of you must have heard the OCT talks. So I'm just going to discuss something a little different on the concepts in the newer OCTs. The OCTs, of course, has gone in for a huge revolutionary changes in the OCT. So let's see what are the newer things in the optic nerve head and as well as on the posterior pole analysis as the newer option, the OCTs. So let me just talk something on the optic nerve head. So you can see the BMO here, which has been mentioned there. BMO is nothing but Brooks membrane opening. So we'll be keep talking about this, the relevance of this BMO in the coming slides. When you're looking at the fundus, the confusion is what is the true disc margin and the boundary, especially in cases where the disc margin is not very well defined. So you're confused of what exactly is that. So when you use the ophthalmoscopy, either by direct or indirect or by 78 or 90, whatever you use it, we always look at the scleral canal, that is the scleral ring, as the border of the optic disc. That is typically how we look at it in clinical examination. But in the OCT is little different. What we look at is the termination of the Brooks membrane opening. That is a disc margin, which is, you can see here is green and red. The green is the scleral border and the red one is the Brooks membrane opening. You can see that clearly. So looking at this picture, you can see the red dotted circle and the green one. The red one is the Brooks membrane opening and the green one is the clinically assessed disc margin. It is completely two different pictures you can see. So is that we use only the Brooks membrane opening, or is it really good for us? So there are many clinical studies to show that the Brooks membrane opening has much better relevance to looking at the disc margin as such. So that is supposed to be the true disc margin for the reason the blood vessels and the axons cannot pass through the Brooks membrane. So it is considered as the true structural boundary of the optic disc. So that's one of the reasons why the recent OCTs, they concentrate more on the Brooks membrane opening. So I'm just talking about the Spectralis OCT, which is the bit more advanced OCT as of today. You can see that it draws about, say, 24 scan lines through the 360 degrees of the disc, that is the Brooks membrane opening. Based on the Brooks membrane opening, it detects about 48 BMO positions to determine the BMO-based disc margin. That is the newer concept, as I was mentioning. The BMO-based disc margin is more important to understand. So how do we really find the Brooks membrane? Is that very difficult? Sometimes, yes, especially the myopic eyes or very distorted eyes, then it is going to be a little difficult to identify. It is basically the wedge-shaped ending of the choroid. You can see here, this is the choroidal area. You can see this is the wedge-shaped, but one can see some cases it may be straight, some cases it can be like this. But once you see the vessels, it cannot penetrate the Brooks membrane. And this is a very, like a rod, iron rod, like a structure where you can easily identify the Brooks membrane. That's not very difficult to identify the Brooks membrane. Of course, the software in the machine automatically gives you the 360-degree views of the Brooks membrane. Here you can see here, everywhere. You can see the orange comes or yellow comes once it is, the thinning happens there. And you can see there is a red area, that means the Brooks membrane is too thin. So, I mean, not Brooks membrane is thin, the neuroretinal rim is thinner. The axons in that area is very thin. So you can see that it is very easily you can pick it up. But once you feel it is not correctly identifying, especially in the myopic eyes, then you can remark that area. So the software gives you that advantage of marking that again. So what is this? There's another concept called the minimum rim width. So MRW, we call it as an MRW. So the Brooks membrane opening with the minimum rim width is a newer concept. So what does it mean? This is the smallest distance between the Brooks membrane opening and the internal limiting membrane is called as the Brooks membrane opening with the minimum rim width. Let's see what is its relevance. If you look at the other OCTs, what I'm talking about is the spectralis versus the other OCTs, the newer OCTs like Topcon or those eyes. These eyes and the Topcon, they use the horizontal rim width. So the horizontal rim width is another concept, and the minimum rim width is another concept. There are two different concepts how the machines take this the centration is. There are many studies which shows that the horizontal rim width is not that good enough. The minimum rim width has yielded a higher diagnostic performance in comparison to the horizontal rim width. That's one of the reasons it becomes more important when you're looking at the nerve fiber layer or the neuroretinal rim. So looking at the neuroretinal rim, as Dr. Kiran was also mentioning earlier, when you're looking at the larger disc, your neuroretinal rim is not going to be that thick in comparison to the small disc. Small disc, the neuroretinal rim is much more compact and it is highly dense. So that's the reason why you see a thicker neuroretinal rim. You can see from here, in this is how the picture, I mean, the chart appears when you look at the MRW, that is a minimum rim width. You see here, we have just mentioned one is the macro papillae and another one is the micro papillae. The macro papillae is the large disc, micro papillae is the small disc. Small disc, as you can see here, the dotted lines, the large dotted ones, shows that it is much thicker. The neuroretinal rim is much thicker. And you can see the small dotted ones is the macro papilla where the neuroretinal rim is thinner. But this is again normal. This is the average disc, this is a small disc, and this is the large disc. So you must be careful when you are looking at the disc size and understanding of the velocity, where it can lie. Not only that, when you see the hyperreflectance surrounding the disc, we must understand that there is something called as the peripapillary atrophy, which is normally seen in majority of the population. And there is something called as the conus temporalis. Conus temporalis is more commonly associated with the myopic eyes. So we should not get confused with the PPA and the cone. Both are two different concepts. Well, one can have both PPA as well as the conus temporalis. In glaucoma, the PPA is much more important than the cone as such. So looking at these three zones, there are three zones. One is the alpha zone and the beta zone. These two zones, which we many times we must have heard about this. So the alpha zone is actually the Brooks membrane is present, and there is an irregular retinal pigment epithelial layer. So that is the alpha zone. Looking at the beta zone, the Brooks membrane is present, but there is no RPE. Looking at the gamma zone, the Brooks membrane as well as the RPE both are not present there. So these are the three zones which we must understand, the three zones. I'm not going to talk about this. Probably when time permits, I'll talk about the C curve, that is the corneal curvature reading, how it is relevant in OCT. We'll talk about that little later, in case we have time. So this is how the chart appears to be when you want to really read the OCT. So this is the Brooks membrane opening minimum ring width analysis chart. You see there are three lines out there. One is the black line. That is the one which you have taken today's OCT, so the black line, where the neuroretinal rim is, how the neuroretinal rim is. Then you have a green line here. It's very lightly seen here. The green line is the normative data which is being given by the machine. Then there is another gray line down which shows that the baseline data of your whatever you have done, the baseline data. So you can compare how the change has happened over a period of time. This is today's, and this was the baseline, and in between green is the normative data. So you can see that this is how the classification chart will appear. The minimum rim width classification chart will appear. You can see the thickness here, and this is all in percentiles. It is different from other machine. So this is in percentiles, which we need to understand. When we have time again, we'll discuss over the percentiles. So when you come to the nerve fiber layer analysis, we have a 3.5 ring, 4.1 and 4.7. As the ring goes periphery, you can see the bit of a thinning. Similarly, this also is important. You see here, this is the OCT picture, but make sure that you can see the vitreous also, but in this picture you can't see the vitreous. But if you can see the vitreous, if there isn't any attachment of the vitreous, that is going to be again critical. That might be just pulling the ILM, and also it appears to be the thickness may appear more, so you got to be careful. So it is not enough if you just see the chart alone, but you have to see the OCT picture as such, and also the graph you must see. Where exactly is thinning happening, you can isolate from the chart than from the BMO, the neuroretinal classification. This is all the average, but you have to look at each location separately and then identify whether there is any change which is occurring in the local area. So this is the classification chart, which is similar to the MRW chart. So coming to the posterior pole asymmetry, we were not doing this in the OCT earlier days. Now, of course, most of the machines, they do have the GCL, that is the ganglion cell complex, but we have the nerve fiber layer, retinal nerve fiber layer, ganglion cell layer, and the inner plexiform layer, all the three together called as the GCC. But what we can expect in this particular machine is each of these layers can be separated only in the spectralis OCT. Other OCTs, the ganglion cell layer and the inner plexiform layer will be coming as together. Retinal nerve fiber layer separately, ganglion and inner plexiform will come as together. I'll just talk about that importance if we can go through later. So what is the smallest measurable change that we can appreciate in different machines is the spectralis gives you about 1 to 2 micron change happening in that area can be picked up in comparison to the Cirrus and Ophthalmic, which picks up about 8 to 10 micron the measurable change, the smallest measurable change. That means close to about 20% difference we can see between these machines. So that's not a good thing to happen, but that's how the machines have been manufactured now. So the next concept is on the fovea BMO axis, why it is so important. So you have, we all know that the macula in every eye is positioned differently. So we can see it can vary between plus 2 to 3 degrees to minus 18 degrees of axis when you look at the center from this area. That is a BMO centroid. We call it as a BMO centration. And you can see that how different it is. So how it is being taken? There is a system called the anatomic positioning system in this particular machine. So what it does is it draws the BMO, that is a Brooks membrane opening, and it takes its centroid from Also, it takes the center of the macula and then it draws a straight line. So this is what the fovea BMO centralis axis is. So you can see this. This is how the retinal nerve fiber layer arrangement is. Always towards the macula, the papillomacular bundle comes towards the macula, and you can see this, how much is the difference which is happening here. That's why both the fovea and the BMO axis is extremely important for us to understand where exactly the nerve fiber layer damage is happening. Even if there is a cyclotorsion, it takes care. The fovea BMO axis takes care of even there is a cyclotorsion. It is the biggest advantage of this particular machine, where we can really exactly pick up the nerve fiber layer defects, and all other defects can be exactly picked up. We all know that there is going to be an asymmetry in the glaucoma, visual field damage. So similarly, so this is how the posterior pole asymmetry analysis will appear to be. So there is a grid here. You can see the big grid which shows the retinal thickness map. This is called as a volume scan in the area of 30 degrees to 25 degrees. There's a volume scan. So each one you can see that 245 or 265, whatever the numbers, you can easily pick up the thickness of the retinal area. Then you have something called as a asymmetry map. Between the eyes, we have asymmetry. You can see this is the between the eyes. So in these areas, the thinning is more than the other eye. And more the gray, then you can see more the damage. If it is more than about 25 micron thickness, then it becomes more darker. You can see here, in comparison to this eye has more damage in this particular area. Similarly, you can say even within the eye, how the superior versus the inferior is changing. You can see in the other eye also. So this is how we can pick up. And also it shows how much is the average thickness in the superior versus the inferior areas of this. And then you have this. So this is how the asymmetry of the eye can be picked up. Also, we can pick up each layer separately. Like you have the retinal nerve fiber layer, you can pick up the full retina thickness change, and then you can pick up both the retinal nerve fiber layer map separately. Then this is how the asymmetry can be seen, and this is the ganglion cell layer map. You can see how much is the variability happening here. You can see each area by area, the squares. You can see between the eyes. You can see between the zones, superior versus inferior. You can see how much is the difference. So this is how we can easily pick up inner plexiform layer. You can separately pick up. So the posterior pole, you have the retina, RNFL, and the GCL and IPL, and we have the asymmetric chart also we can easily see. Not only that, we can understand how the structure function correlation also. If you don't do the visual fields also, we can reasonably pick up, but we cannot directly correlate that. So there is something called as a food map is available in the spectralis. The food map exactly picks up where exactly is going to be your visual field change in this. So that's how, and there is something called as the heat maps. So when you have the colors may be limited. So sometimes the red goes, the thickness goes a little bit more. From red, it suddenly appears to be white. So that's how the color map can pick up. But the heat maps will gradually increase its strength to show it's not a gross difference. So the heat maps are going to probably replace the color map in the coming years. So whatever it is. So we have the deviation maps also. So this is very easy for us to explain to the patient how much is the damage happening there. So patients can also easily understand how much is the change happening there. This is also you can easily say for retina, and you can pick up for the retinal nerve fiber layer, ganglion cell layer, and IPL separately. So we can understand each layer how much is the change happening. So this is the Zeiss OCT. I don't have much experience with the Zeiss OCT, but what the exact problem in this is the fovea BMO axis is not marked. So that could be one of the potential errors in the other OCTs. So just to show how the Zeiss OCT will appear. And this is the top 10 OCT. All of them now they show the GCL. So you can easily pick up the GCL change occurring. This is the comparison. So, and the last one is on the trend plot. We can easily identify where exactly each area we can identify and see where is the change happening. That is another advantage with the spectralis. Every location we can pick up and see how much is the progression happening in that particular location. So what is that I have learned over a period of time and looking at the OCT is never read the OCT in isolation. It is better to see in the slit lamp that is, and also if you have the fundus photography, that is the best one that you can look at and compare it. But always use the desktop screen, not your printed materials. It is not good enough. Use your desktop screen to access the OCT and check the OCT is okay, because there's always going to be a lot of errors which can be there, and read all the charts to understand well before you make a decision. It is, I know that it is very simple to get the file and see one chart, the color coded chart, red, green, and yellow, and then say this is normal or abnormal, but that's not the way to go. But I take at least minimum of 10 minutes to screen through every OCT picture to understand what's going on. So don't hurry up to read. You may miss many points which may be very, very essential for you to treat. So thank you for your presence.
Thank you, Dr. Satyan. I think in this voyage of glaucoma diagnosis and management, maps are so important. So you have given really the futuristic view of how things going to be, and where we actually marry this clinical evaluation and skills to the investigations, and where the future, where we are heading. You have given a bird's eye view. Excellent presentation. I think there is so much to learn, not only for postgraduates, for all the people who are practicing glaucoma, from where the future is going to be. Thank you very much for a very lucid talk.
Thank you. Thank you so much.
I think if there are no other questions for you, I think without much ado, I think we'll probably go, because already we're losing time. We are just in the halfway mark. I'm the fifth speaker. We have 5 more talks and we need to finish. And there's a little extra time they have given to us. I think with the permission of the chair and other people, can I start?
Please go ahead.
Go ahead.
Yeah, please.
So thank you so much for all my friends at COC and KSOS and all the good friends in this panel for having me here. I'm really enjoying this. I'm learning a lot from this. Hope all the people who are watching this, especially postgraduates, they're really fortunate to have so much of star faculty in this glaucoma module. So my topic is how to evaluate a case of glaucoma suspect. See, normally this talk, I want to design it for basically 2 kinds of people: the postgraduates who probably are embarking on this journey of glaucoma management. So give them some ideas, some nuances, some kind of inspiration, how to evaluate, how to suspect a glaucoma in your routine practice, and how to go about actually evaluating them, either ruling out glaucoma or diagnosing or confirming it. And also some tips to especially the comprehensive ophthalmologists who also share this whole burden of glaucoma management in our, because there are very few glaucoma specialists so-called, and the majority of the burden lies on the general ophthalmologist and the comprehensive ophthalmologist. So when do you suspect? So I'm just going to do that. See, I do understand that everyone is worried about a glaucoma suspect because of its blinding potential. When a patient comes with some borderline IOP rise and some PXF here and there, and if you don't really do enough, if the patient goes away from you and comes back after 3 years, you may find that he's almost virtually blind because you probably missed an evolving PXF glaucoma, which probably became high pressure glaucoma, and he lost vision considerably because we lost out on his suspect. We didn't do enough. So these experiences make us, sometimes push on the brink of over-diagnosing, rather over-treating certain patients who otherwise do not do it. So this blinding potential and the irreversibility of a glaucoma blindness is what really, affects our thinking and clouds our thinking. And the second is, when you probably say the word glaucoma, many patients would know what glaucoma is, if not immediately or at least later. And the cost of the therapy, the cost of investigation, the cost of follow-up, and the emotional turmoil or the kind of cost of the emotional trauma is something very, very sizable. So we have to be careful enough to not to put a label without much justification. And so this is a very difficult task to really bridge the, the doing justice to the glaucoma suspect, at the same time not overdiagnosing things. So this underdiagnosis and the overdiagnosis are two perils that always, trouble a glaucoma specialist. And a glaucoma suspect can be, for all the postgraduates here, can be a disc suspect. So you look at a disc, it looks like, Dr. Kiran very, lucidly told how a disc evaluation has to be done. So you may find a disc to be suspicious. Okay, this is something that you have to know, that in a routine examination, patient has come for something, you have to look at the disc always, and you have to probably rule out a glaucoma there. And an IOP suspect, a routine IOP examination for any patient coming after 30 years. And there are in specific patients, in routinely, even in children, there's some specific indications to check intraocular pressure routinely. So you have to suspect that this could be an IOP rise, and probably patient is a potential glaucoma patient. Sometimes you do a gonioscopy when you look at some anterior segment features and you suspect certain kinds of glaucoma there. And sometimes you just have a perimetry for some reason. Okay, and then there is some field effect coming up. So you can, to complete the whole picture, you may have even a perimetry suspect. But a disc suspect and an IOP suspect are the two important aspects of this suspicion. So what is an IOP suspect? When you have pressure slightly out of normal rate, let us say a patient comes for a presbyopia correction, his pressures come out to be 26. So what do we do? This looks normal. Okay, should we do a perimetry? Should we do a gonioscopy? What do we do? Basically, you need to first standardize your suspicion on IOP. So you have to check, recheck the IOP multiple times. So if the patient, if not in the same visit, you can call him on some other day, on some other time of the day, and try to see whether the IOP. So you can probably not, jump onto something and start, something very, very outrageous. First, be sure that his IOP is actually outside the statistical normal. Do a diurnal variation wherever possible. See, it is very important to have how the IOP fluctuates. Probably you may be seeing the patient in the trough or in the crest, so you never know. Maybe the pressure what to record at 26, maybe actually the patient may end up with 40 pressure sometimes, or that may be the highest pressure that you record in a DVT. So getting this DVT and seeing how much fluctuation that happens is an early sign of glaucoma. It is not just the degree of IOP elevation, it is the degree of IOP fluctuation which gives a disturbed trabecular outflow facility. And obviously you need to standardize this with a corneal thickness measurement. Okay, normally very high IOPs, you don't have to really worry about it, because the amount of correction that you probably make may not make any difference to the final outcome. But any borderline pressures, like pressures of 24, 25, 26, so you need to probably see, are you dealing with a thick cornea? You need to probably do an corneal thickness CCT corrected. And obviously, you need to look at the optic nerve head, which is a part of the comprehensive examination. With an IOP slightly on the outside the normal range, you need to look at it more carefully, because the eyes won't see what the mind doesn't know. So you need to look at it, and wherever possible, you need to probably do a perimetry to probably confirm or corroborate the disc changes. And a disc suspect is something very, very important. Dr. Kiran alluded it very excellently. So how never miss an opportunity to see a disc, even in an undilated patient also, it's no problem. You try to master the at least, because you're not trying to look at the equator or beyond that, just the central fundus. I think every postgraduate should learn how to see. Okay, now we cannot use direct ophthalmoscope most often, so learn the habit of seeing the central fundus, disc and macula, at least with a normal pupil, because you may not be able to dilate all patients. When you see something suspicious, you can probably continue it with a dilatation. So looking for a glaucoma disc, as Dr. Kiran said, the size of the disc is extremely important. That will rule out many things. Cup disc ratio is not very important, but it is something to document. Neuroretinal limb is of paramount importance. Any localized defect, so you probably a suspicion of glaucoma goes up. Peripapillary atrophy, disc hemorrhages, and RNFA defects are something that you always have to look for, which will probably require a dilated examination. Angle closure glaucoma suspect. This is something very easy if you really focus on it. The anterior segment changes, especially a small anterior segment, shallow anterior chamber, central depth, and a peripheral AC depth using a Van Herrick's, which came out in 1969. is something very valuable, at least to start off your train of thoughts. There are certain specific situations where you can expect, there are a lot of diseases which can come out with, as even Dr. Gopal Pillai said, even a BREO can give you an RNA field defect. It can have sometimes many of the non-glucomatous conditions can give you a defect which may not progress. So one-time perimetry is of no value if you do not correlate with what is causing this perimetry defect. Okay, so with putting everything together, I would like to give you 10 commandments, how you go about evaluating or at least looking for a glaucoma suspect. In a routine practice, where should you actually suspect glaucoma? So I'm going to sharpen your surgical skills and give you some tips so that every postgraduate, every comprehensive ophthalmologist will not miss a glaucoma. So let us get started. So what is commandment number 1? I think we always say, I got a OPD of 150 every day, I can't probably look for a glaucoma. It is absolutely wrong. I think a busy person is more trained to find time. Okay. And a busy OPD is not an excuse for incomplete examination and suboptimal management. You can always, if you have it in your mind, you can always pick it up. And we Indians, as we are trained to see more patients in lesser time, I think we are the best bet to pick up a glaucoma. If you can't do it in 2 minutes, you cannot do it in 20 minutes. And history, as always we tell a postgraduate, is extremely important. See, you have to spend some time whenever you are dealing with a glaucoma suspect. There are a lot of pointers to history. In fact, if you ask the right questions and patient enough to listen to him, I think the best pearl of communication is to shut up and listen to the patient. So if you just allow the patient to talk, he will come out with even the diagnosis. So many a times the patient won't even show their eye drop that they are using. They don't tell because many a times they are rushed into, we keep asking questions, we interrupt. It is said that a study shows whenever a patient starts talking, most people interrupt within 20 seconds. So you just allow the patient to talk. There are a lot of vague complaints about headache, eye ache, sometimes intermittent blurring of vision. Colored halos may not be, classically present in most, but this particular thing, they go to a movie, pupil is bit dilated in the semi-lit condition for 3 hours. They come out with a splitting headache. They blame the director of the movie, but probably they must be having a subacute attack. So ask the history properly. Frequent change of glasses, again, a very classical thing. Family history. I think if you are many things, it runs in family. This is something. If you have already a patient of glaucoma, please screen the family members. Your chances of picking a glaucoma is much higher. So family history is something very, very elementary. And many a times we don't ask when somebody comes with a totally opaque cornea or an absolute eye. We just write absolute eye. We don't describe anything. If you ask the patient, how did he lose vision in this eye? Probably there is a glaucoma behind the whole scene. I think if you probably ask the details of the loss of vision in one eye, many a times it may point to that probably you should be suspecting glaucoma or there is a forerunner of glaucoma in this eye. So just because it has an opaque cornea or it is no PL, you have to really go into why it has actually, patient has lost vision in this eye. So very importantly, all hyperopias, see, you know that angle closure glaucoma is more common in hyperopics because of small anterior segment and the typical biometric changes. Moderate to high myopia, again, so many a times we miss primary open angle glaucomas in myopes, which is very important. And the patients who undergone LASIK, obviously there is no myopia right now when you see them. And when you see that the patient is emmetrope now, that thing goes away. So you should never lose that the patient is having a predilection to open angle glaucoma even after refractive surgery. Number two, very importantly, you have thinned out the cornea and especially myopic classic. So whatever IOP you are measuring probably has to be corrected for this CCT. So you may have to add 2 or 3 or 4 millimeters of mercury to the recordings that you see. So thin corneas can sometimes be, can mislead you in these patients. And very importantly, a lot of children who undergo a cataract surgery for their developmental or congenital cataracts do develop glaucoma over a period of time. It was more common earlier when our surgical techniques were not very well evolved. But even today, because we understand that cataract is a developmental problem, we can also expect some associated outflow facility problems in the same child. So it can't be an isolated cataract problem. So obviously, you can think that the child probably will develop some problems with the outflow and develop glaucoma over a period of time. So any patient coming with a follow-up patient, a pediatric pseudophakia or aphakia, we have to look for intraocular pressure. And next is beware of ACG. This is something, as Indians, at least half of our patients are ACG patients. This is something easy to pick up. And I'll always tell my postgraduates, you should not miss an ACG because you have a chance of curing the patient potentially if you do a YACP at the, say, right time. So giving a iridotomy at the right time can be extremely, helpful for the patient. So never miss an ACG. Don't allow it to continue till the angle damage happens. And treating the fellow eye is probably very important. So shallow AC, suggestive anherics, and very importantly, look at the iris. There are some telltale signs. Iris overling, iris atrophies here and there, and distortion of iris pattern and pigment dispersion. These could be subtle signs that you know that there is some subacute attack or some kind of an iris ischemia happening intermittently. So looking at the iris, looking for this pic, when it is very obvious, people may not miss it. But in the very early stages of these iris changes, you should actually be having an eye for the iris changes in this. And very importantly, PXF. In India, this is a very common thing, especially in South India. So PXF, when there's a PXF, even though the pressures are normal, don't let them go out of your radar. The next visit, the pressures may go up. In the same day, some other time, the pressure may go up. A TVT would actually reveal this factor. So PXF patients are bound to have very high fluctuations. So the glaucoma progression is much faster compared to a normal POAG patient. So it can be disastrous if you miss out a PXF, especially the fellow eye of a PXF absolute eye. Like you have an absolute glaucoma, which is obviously a PXF glaucoma. The other eye does not show any changes of PXF, very obviously. But still, you need to follow this patient because it's likely, the history is likely to repeat in this eye. So you should be doubly careful that it will not happen. See, normally, whatever happens in the second eye, usually you can get a clue from what is the history of the first eye. And myopia, again, I said, is another thing which you have to take care. What is important? Should we do a IOP measurement routinely for all patients who come to the OPD? You can have your own, you can probably do it on every patient because of the non-contact tonometry is so simple. Or else you can fix up some age limit like 25, 30 or whatever. But at the same time, there are certain patients like children, I told you, pseudophakias, aphakias, the children on steroid eye drops, children with a family history of juvenile glaucoma in the family. So they need to we need to check it up routinely. So you can probably have your own rebound tonometer and eye care tonometer is extremely convenient. Now NCT is again, you should understand NCT does not measure IOP very accurately. It always underestimates a low IOP and overestimates a high IOP. It just gives an idea, some idea about what could be the IOP, not exactly. You need to do an applanation tonometry for sure in these patients. And you can have high risk patients, you can probably have some kind of a protocol as per the institution policy. So any IOP more than 22, beware. That's probably the cutoff line to start thinking about it. Always perform an applanation tonometry, correct it for the central corneal thickness if necessary. So office hour DVTs can be done. Sometimes we do even 24 hours DVTs and multiple recording. That is very important. The patient can come repeatedly for you. Ask him to come multiple times, see that 3-4 times in different timings on different days to get an idea what could be the fluctuation. And very importantly, for all postgraduates, let me tell you, you don't have to always use a gadget to measure the intraocular pressure. You can get a fair idea of what could be the range of IOP, whether it is low, whether it is normal, or whether it is high, just by feeling the glow. So put your thumb on the slit lamp examination, put your thumb on the lower lid, just feel the glow, okay, and just get an idea on your fingertips, like what is the kind of pressure the globe has. When you keep doing it on routinely the patients, you will develop a calibration, whether it is high, normal or low. So that is something very important, which you can do it on your post cataract patients, surgery patients to get an idea whether the IOP is high. So similarly, make this as a habit. It becomes very important clinically for you, because what is very important about intraocular pressure? See, that is not everything. So we have certain studies to show, like we have an ocular hypertension treatment study where they followed up for 5 years with 20% reduction. And in the treatment group, around 5%, okay, had progression. and in the untreated group, around 10% had progression. See, what does it say? From what it meets the eye, you need to probably extrapolate some information. What does we don't normally directly see from it. That means 5% progressed despite reducing the intraocular pressure, and only 10% progressed without treating them for even 5 years. That means intraocular pressure is not a very disastrous thing that you need to recommend, manage it on an immediate basis. So look at its study. It says that you can take your time. If you're in doubt about IOP, don't start a medication. This is a very knee-jerk reaction of many of the patients. Like when you have a IOP of 30 or 28, they start a latanoprost, they start a timolol, and then they're referred. So already you're spoiled the scene of crime. You altered the situation. It will take a long time to take the patients off the medication, allow for the washout period. So don't start any treatment unless you are very sure of the indications to start a medication. Because intraocular pressure, the patient must be having a high pressure for many months and years before he came to you. So just waiting for a few more days will not really make any difference to the final visual outcome. So just hold on. So similarly, even when you have an actual glaucoma, I'm not just telling an IOP elevation, even in patients in an early manifest glaucoma trial, okay, 6 for years, if you do not treat a patient also, 62% progress, which is very well accepted. But even in a treated patient, 46% progress. That means just you control an IOP, that is not the panacea also. The other side is also true, that just because you manage the IOP, you have finished the problem and you're at the end of it. So there is a possibility that non-IOP factors also working. So always hold on to your nerves, wait for some time, and see that you have a proper database, you have a proper evidence to start treatment. So what are the risk factors of progression? This is very important. When you have a very high IOP, obviously it is going to progress. If you end up with a patient with 45 IOP in your OPD, you can't let him go like that. Obviously, he will continue to progress. In a follow-up also after treatment, the pressures are still not coming relenting. Then again, that's a high risk. Old age patient tend to progress more. Lot of fluctuation. I told you one, then a single value, more fluctuation. Like somebody has an IOP of 10 in the morning, goes to 24 in the evening, he's more likely to progress. And if you already have a damaged disc at baseline, so a damaged optic nerve head is likely to be more vulnerable for disc damage further than a normal healthy disc. Race, obviously, there are ethnic factors and racial factors. Disc hemorrhages, again, though they can, harbor a problem, they can be harbingers of further glaucomatous damage. And PXF, I told you, can add an extra risk to already an existing glaucoma patient. And thin corneas not only alter the intraocular pressure measurements and give you a false sense of security by erroneously recording the pressure lower, they by themselves also an independent risk factor for progression. So you need to move from the cause to the effect. As Dr. Kiran said, it's not important to look at the IOP. IOP can vary, even you can have progression with normal IOP. But what is important? It is the disc which gets damaged, giving rise to blindness. So look at the disc. So disc is paramount. IOP can be anything. Look at the disc. If you have a suspicious disc, if there's an evidence of a disc damage, this is the patient to investigate and to spend your time. Not just, so looking at a disc and declaring it as normal or abnormal is something very, very important. So optic nerve head evaluation, the importance cannot be overemphasized. Probably the very specific part and a very important part of glaucoma diagnosis. And as I told you, you should always, wherever you don't have a time and resources or the logistics to dilate a patient, at least see the disc with an undilated pupil. Don't postpone it. And strong family history, always beware. Hypertensive on beta blockers. When you ask patient as a hypertensive, please ask the next question. Try to find out easy on beta blockers. So many of them will be on bisoprolol, many of them on atenolol or propranolol. So that can blunt the IOP and you may be recording the IOP normal, but actually the patient is already having a systemic beta blockade. High myopes and small anterior segments. Okay, you have POAGs and PACGs in these patients. Patients on steroid drops. I think any patient can be a steroid responder. You can't assume that he's not responding. So even 1 week is good enough for some people to have a high IOP rise. So please make sure that if you are using steroids for whatever reason, use it only for the appropriate period. And when he's on steroids, make it a point as a protocol to measure the NCT as, it's like it should happen by default. It is not that you have to think every time. Make it a protocol, make it an SOP. When you start steroids, you have to look at the IOP after 1 week. So so that you will not miss an IOP rise. And this is the most, I think Dr. Gopal will agree. In our institution, the retina department contributes a lot of work to us. They put silicone oil, they give intravitreal steroids, they do surgeries, and lot of intractable glaucomas, are basically pumped in from retina department. We have a very good, give and take policy. So intravitreal steroid injections, beware, invariably you will have IOP rise. Sometimes it can be really detrimental for the patient. Probably to improve his vision for 2 lines, you may be giving an intravitreal injection. For a cystoid macular edema, from 612 to 66, you want to take the patient away, you're giving an injection. But since you have not managed the IOP, the patient may lose his vision at all. So make sure that we are not overdoing certain things. And a patient with thyroid disorders invariably have POAG-like picture, which is quite intractable to treat sometimes. So lastly, special situation. See, many a times, a lot of post-operative patients, unrelenting corneal edema, they are referred after 2 months, 3 months for a keratoplasty or a cornea opinion. But we find that the turbulent or a very traumatic intraocular surgery that happened not only damaged the endothelium, probably it also damaged the outflow mechanism, and the patient developed a high IOP, which has been masked because of the corneal edema or because the surgeon was ignorant about this element. So the intraocular pressure has been completely ignored. So by the time we do a keratoplasty, we find an glaucomatous optic atrophy, or we find the eye to be pretty hard when actually the patient is referred for a corneal graft or a cornea management. So make sure that they can coexist, or just a high pressure can be confused for a corneal decompensation. Closed globe injuries, I think this is very important. Many of the high FEMA patients who come, you may probably miss out on an IOP, even though it looks very nice, but sometimes the IOP can be the only problem. And as I told you, silicone oil and intravitreal steroid injections, again, a very a reason for intractable glaucoma cases. And even though the vitreous surgery has really gone well with silicone oil, the patient sometimes loses vision because of an unrelenting glaucoma, or that we are not managed it. And the last commandment, what about the investigation? Dr. Satyan, gave an excellent view into the future of OCT, but still, he will probably agree with me that perimetry is still the king. If you have a choice between investigations, first you need to opt for perimetry because it's a functional test. It actually records what the patient has lost. Structural damage precedes functional damage, but without a perimetry, no investigation actually, because the database for all these investigations are still evolving. There is so much of variability in the results that we have in these optic nerve head imaging techniques. So perimetry cannot be left out in the race. It is the first thing that you do, and that is the most important follow-up. Okay, what Dr. Andrew Briganza actually told in his extensive talk. So the newer imaging techniques, so these are evolving. Obviously, this will obviously supplement the perimetry. You need to kind of get a correlation between the two. Okay, and finally, everything, whether you are doing a perimetry or you are doing an imaging, clinical correlation, unless you see the patient repeatedly, look at his disc, look at his angle, look at his intraocular pressure, DBTs, I think nothing will work. I think finally, you can miss glaucoma. It can be easily missed if your mind is not open to it. Okay, that is something very important. And it's a comprehensive exam. Patient will come for any damn thing, whether it is glasses or a chalazion or a stye or a pterygium or a retina problem. Please look at his intraocular pressure, look at the disc at least, and wherever possible, look at the gonioscopy. And obviously, clinical findings are important than the OCT. There may be a reluctance of the present day regeneration to do clinical examination, order investigation, just like that, but they have no value. It may lead to overdiagnosis, it may lead to unnecessary concern and probably overtreatment. And I told you, history, routine IOP, and disc evaluation is very important, and still stick to perimetry. So thank you very much.
Sir, if you
as
don't,
usual, 10 Commandments, great new Moses of glaucoma. So I think we're running short of time. Can Gopal or somebody just warn us when we go up around 8 minutes or 10 minutes so that we cut short or wind up? Anybody can just, the organizers can do that.
Yes, ma'am. Yes, ma'am.
Very important points Dr. KP has raised, and just to encapsulate two of my sharing experience in this, family screening is extremely important. And if you diagnose, especially a young patient with glaucoma, please just check his or her siblings once, because you're going to pick up many patients. I had a patient who brought his son of blindness, and this child had the polycystic kidney disease, and he was being given steroids for that, and he was a steroid responder. So we could, the residual life of the child, he did not survive, but at least we could spare vision in one eye because we picked it up because of this father who had glaucoma. And second thing is, we have a lot of pseudophakic children and children who have adults who have had LASIK done. So these post LASIK and post pseudophakic children have to be monitored lifelong. As Dr. KP said, SOP, that they have to be monitored lifelong. When you discharge the patients with LASIK or with pseudophakia, please write down in the discharge summary that this child needs lifelong monitoring for XYZ. And that XYZ, it should include IOP and glaucoma monitoring. And a very classical sign which you can tell the parent or the mother is when this child has a reduced need for near vision. Like normally pseudophakic children have to have a near added glasses. So they will just have myopia. They'll have no symptoms but myopia because of increasing eyeball length with the glaucoma. And if you tell the mother ki agar if the requirement for glasses reduces or changes, it's a warning sign, and please bring these children back. So these should be on the radar of uveitis, diabetics, and LASIK patient, family history, and I think rest has been beautifully covered by Dr. KP.
Dr. KP, one quick comment. Can you hear me? Yeah.
Yeah, sure.
Yeah. Very beautiful presentation. I mean, the thing about the presentation is that these are, a condensation of your own experiences also, apart from science, and this is not something you can actually read somewhere. So thank you. I was just saying that you made a very important point regarding history, right? About taking history. The problem with telling postgraduates or early practitioners to talk about history is that it sounds very cliched. Okay, you have to take history. I mean, everybody goes on saying that you have to take history, But what I would like to point out is that when the American Academy comes out with their guidelines, they usually assign a level of quality to the study, and then they make a recommendation. So talking of history, there are specific points that they have mentioned. For example, talking about history of intermittent headaches and blurring of vision, those symptoms of subacute angle closure attacks, they have classified it as a good quality study and have recommended it strongly. So it is a good quality, strong recommendation. Again, it's not simply cliche. It's good quality, strong recommendation. Secondly, history of usage of drugs. In the form of either corticosteroids or anticonvulsants and a lot of other drugs which can cause angle closure glaucomas. They have again classified this as good quality, strong recommendation. And one more thing they have added, which may not be very significant for us in general, is the history of any prior glaucoma laser. And because they do a lot of SLTs, so a person whom you see currently might have done SLT a year back, and now everything might look normal. But even in our situation, history of a peripheral iridotomy, which we may actually kind of miss, at some point of time. So again, these are all listed as good quality, strong recommendation, which is essentially the highest quality that you can assign. So I'm just pointing out that these are not just cliches.
Yes, I think very important, because it's our duty to train a new person in ophthalmology, especially our postgraduates, in their communication skills and soft skills. I think that is where sometimes the patient may not come out with all the things. Looking at the young man, that probably he's not the boss. When they look at our gray hair or no hair, they will start coming out with more details, because they want to give more details to the main man who is concerned. So that is also there. Taking away from it, if you probably really connect with the patient, and as I told you, listen to them first, give them time to talk, I think that is very invaluable. So thank you very much for adding that point.
So going to the next talk, can we have Dr. Ronnie George speak on trabeculectomy? Can we reschedule it? Is that okay?
So thanks, Manoj. I'm sorry for jumping in the queue, but I'm sandwiched between two talks, so I don't have much of an option. So I'm just going to talk to you about the basics of a trabeculectomy. And since this is primarily for the postgraduates, I'm going to keep it fairly basic. I'm not going to talk to you about indications, but about the procedure as such. So trabeculectomy is a guarded filtration surgery because your ostium is made under a flap. And essentially what you're doing is you're diverting aqueous from the anterior chamber to the subconjunctival space. The aim is to control the intraocular pressure. While that's obvious, unlike most medical management, typically you are doing trabeculectomy when your pressures are not under good control in somebody who's progressing. So here your target range is probably somewhere between 7 to whatever your target intraocular pressure is. So you're trying to aim for lower pressures than you usually do with medications. And this raises certain challenges because this is a fairly narrow range of intraocular pressure to be able to achieve easily, either medically or surgically. And that's why you need to make sure that you're careful about how you open the conjunctiva, whether you need to use a metabolite, how you create your flap, how you create your stoma, and how you titrate intraocular pressures after surgery using releasables, and how you close the conjunctiva. Because all these have an impact on both the lower end and the upper end of the intraocular pressure that you are thinking of achieving. In terms of your pre-op preparation, it's important to control the intraocular pressure adequately before you start the surgery. You may need to use IV mannitol, you may need to Diamox, and some people don't do this routinely, but definitely if the patient has advanced damage or very high pressures, it is advisable to get the the globe soft before you plan surgery. If the patient has primary angle closure glaucoma, perform a YAG peripheral iridotomy before the procedure. If the patient has any other secondary cause, try and address the secondary cause before you drive in for a surgery. If patients have been on IOP lowering medications for a long time, very often they have fairly inflamed conjunctival surfaces. And this impacts the success of your surgery because it leads to scarring. So it's good to control surface inflammation if possible before the surgery. Look for your lacrimal system, make sure that there is no dacrocystitis or a lacrimal system block, because once you have a bleb there, you are exposing this patient to a lifetime risk of increased risk of blebitis or endophthalmitis, and with a blocked lacrimal system, that's much more likely. Most of us would consider using a topical antibiotic preoperatively to make sure that the conjunctival flora sac is sanitized. In terms of anesthesia, everything from topical to peribulbar to parabulbar to general anesthesia has been thought of. Most people today would do it under a peribulbar or a subtenance anesthesia, and this is adequate for both pain relief and for surgical ease. The location, preferably supraonasally first, because that is covered by the conjunctiva. There is more space for elevated lips, and there is better protection, and the surface is lubricated by the lids. What is important to remember is that you never do an inferior trabeculectomy because the rates of infection are just unacceptably high. Always remember that we have to plan for the future. Most glaucoma surgeons know that our trabeculectomies don't work for a lifetime. So don't use up the entire real estate in the superior sclera to do your trabeculectomy so that you have no space for future procedure. So you go supraonasal and you probably leave space for 1 or 2 more procedures in the future. In terms of exposure, you can use a corneal traction suture, which is better. You can use a superior rectus too, but then the risk of a hematoma is a little higher, and blood induces fibrosis and therefore is not something that we're very keen on in a glaucoma procedure. So in terms of the conjunctival opening, you could either open it at the limbus, and it's called a limbus, at the limbus when it is called phonic space. So what is important when we talk about is limbus base basically means that the flap is based at the limbus. Your opening is posterior to that at the conjunctiva. And we typically try and do a limbus base when you have very thin conjunctiva or perilimbal scarring. Nowadays, most of us prefer to do a phonic based flap where you open at the conjunctiva and the base of the flap is at the phonics. You make a peritomy which is adequate and you dissect posteriorly and sideways so that you have enough space on both sides. And so this is basically somebody with traumatic glaucoma. You can see that there was an iridodialysis there, a subluxated lens, and he was planned for a trabeculectomy with a sleeve fixated lens. So you're just opening the trap flap there and cauterizing adequately. We tend to use antimetabolites routinely, and in that case, most of us would typically prefer to use mitomycin. The concentrations range from 0.2 to 0.4 milligrams per minute and per ml, and you would use it for 1 to 3 minutes.
You apply it using a sponge placed under the conjunctiva, or you could try injecting it. Most of us currently use a sponge. It is important to remember to wash this out adequately. I'm not going to talk to you about how to dilute the mitomycin. That's something that you need to look at the actual vial that you're using and then figure out how to dilute it. The flap can be multiple ways. The flap can be triangular or rectangular and can be usually 3 into 3 millimeters, but I'll talk a little bit more about that. And this is how you would make the flap. You would make a groove there, which is about 50% of scleral thickness. And then you dissect, trying to keep the flap not have ragged edges. You can either use a knife or you can use a crescent to do the dissection. And here we are placing the mitomycin flap. That's with the Vexel sponge. When you're placing the mitomycin flap, make sure you don't make sure you don't touch the conjunctival edges. Before you enter the eye, it is desirable to do a paracentesis because that lets you do gentle decompression and gives you access to the anterior chamber both intra and post-operatively. If you want to look at filtration or if you want to look at flow, that helps you. You can use a trab stoma. When you make the trab stoma, you have two options. A trabeclectomy stoma is basically made in the bed of your flap, and you can use either a Kelly sponge or you can use a Vanna scissors to make it. The stoma, if your flap is 3 by 3 millimeters, is approximately 1 into 1 millimeters in size. And that's essentially how you would make a stoma. So this is a Kelly sponge, and you can see that you're cutting almost at a 90-degree axis. And that is a little stoma there into which you do an iridotomy. So a couple of steps that you need to remember about that. So you can use a trab or a Vanna scissors to make the ostium. Like I said, it should be 1 into 1 millimeters for a 3 millimeter flap. Avoid injury to the ciliary body, and this can happen if you dissect too far back. And this is the region where you make the window. So you go into the clear cornea and you cut back to make the window. So removal of the trabecular meshwork is not mandatory. Removing it helps because at that time there is theoretically some flow through the Schlemm's canal too, but we are not obsessive about doing that. So when you look at a flap, a triangular flap, this is what you would have. You would have the ostium in the center of the triangular flap so that there is a 1 millimeter overlap on each side. And this is basically an equilateral triangle, which is 3 millimeters each way. So very often you find people who make larger flaps or smaller flaps, and it doesn't really matter. What matters is how much overlap you have. Same thing goes with shape. You can do a rectangular flap or a triangular flap. But what again matters is what is the overlap from the edges. This overlap is what decides how much flow there will be. If there is a lot of overlap, there will be more flow. If there is very little if there is a lot of overlap, there will be more resistance to flow and less fluid will flow out. If there is very little overlap, then you will have a lot of flow and you're more likely to land up with a shallow anterior chamber or hypotomy. So shape doesn't matter, size doesn't matter. What is important is that you have a decent overlap. It is also good to dissect anteriorly into clear cornea because you get you're entering the eye a little bit more anterior and less likely to damage angle structures. The thickness of your flap is half to 2/3 thickness of the sclera. It's also important to direct flow posteriorly, and I will tell you why. Suppose this is your flap and this is where you have placed the sutures. Now you're going to have fluid leaking out from between the sutures. If you look at the picture on your left, what you're seeing is that this fluid leaking out both anteriorly and posteriorly. With this, you can sometimes get a bleb which is more anterior. And a more anterior bleb is more uncomfortable for the patient because you have a little overhang just over the cornea and the tears don't really spread well with that. And that can cause some amount of dryness and even a Dellen formation. While in the picture on your right, you can see that the flow is directed posteriorly, and that's the safest place for a bleb to be. Posterior diffuse blebs are what we're aiming to do with the trabeculectomy. So why do we need to do a peripheral iridectomy? And this is basically because when you have flow, the lens can move forward. And when the lens moves forward, you can land up with a pupillary block. And if you land up with a pupillary block, you land up with iris bomb and other issues. So when you have a peripheral iridotomy in place, you avoid the pupillary block, and you also avoid the iris from going and blocking the ostium, because that's the other thing that happens when the pupillary block comes, when you have the lens moving forward. So the peripheral iridotomy should be larger than the opening of the ostium. And it's important that you achieve that because if the pupil is dilated, you can even use dilute pilocarpine to just constrict the pupil and wash out prior to the iridotomy, because you can land up with a sector iridotomy too. The flap closure is probably one of the most important parts of the trabeculectomy because this is where you decide how much flow there is going to be. you need to titrate the tightness to make sure there is some flow, but not too much. It's good to use releasables, or if you're planning to use suture lysis after surgery, that's also fine. It's important to mark the critical suture, which is the most important suture in terms of flow. Make sure that your antechamber is well formed on table, because that is much easier to deal with than overfiltration. It should be just slightly leaky and not too leaky, because the last thing you want is a shallow antechamber the first postoperative day. Releasable sutures, I will just demonstrate what they are. They are a way of adjusting flow so that you can remove them post-operatively. Basically, what it means is you come out through you make a flap, partial thickness through the cornea, you come out through the flap, come onto the surface of the sclera, and you tie a. So what you're doing here is coming in through the cornea, partial thickness. I'm not sure you saw that. Anyway, so you take a slip knot here and you can release it by just pulling this. This dotted area is where you take the track to start with so that it is buried. I will just show you the video once again. Here I'm doing a reverse bite so that the suture stays buried. Here I'm coming in through the sclera, and here I'm taking 3 throws on that. So now if I just pull this suture will open up and flow will happen. And this can be done anytime post-operatively. Early post-operative is more likely to work than late post-op. In terms of conjunctival closure, it's important to be meticulous and try and achieve airtight closure. So typically most people would use 2-wing sutures with or without a horizontal mattress. You can use a variety of sutures, either 10-0 nylon, 8-0 Vicryl, or 10-0 Vicryl to do this. And that's a matter of preference. But it's important that it should be watertight. You can expect some retraction, and a conjunctival mattress suture helps to minimize that. You have to be extra careful if you use antimetabolites, because they can impact wound healing at this level too. So this is essentially basically just a wing suture being taken, and you're going through the conjunctiva there, and you're tying it tight. So it's important that you tie it tight, and you tie it in at the limbus where there is a good grip and not onto the. So this stretch is important to minimize any leak. So post-operatively, what do you do? On table, give a drop of cycloplegic and give a drop of steroids, because that pushes this lens iris diaphragm back and prevents a shallow anterior chamber. Post-operatively, give topical steroids with a slow taper. You may need to use steroids for 8 to 12 weeks or even longer, because the wound continues to modulate after that. Give cycloplegics if you are suspecting a shallow anterior chamber, and in initial stages, it's good to give cycloplegics for everyone. Follow-up is fairly frequent, much more often than you do with a cataract. Typically 2 to 3 times in the first week, and after that every week or 10 days, or even more often depending on what happens. So trabeculectomy is still the mainstay of glaucoma surgery, and it's a procedure that any general ophthalmologist should be familiar with. It's a relatively simple procedure to do, but it can be very unforgiving and very unpredictable. So you have to use meticulous attention to detail as to how you're doing things. And preoperative counseling is probably as important as the procedure, because there's a high short-term complication risk. Almost 30% of patients will land up with something or the other. And it's important that you warn them about that before you do anything else. Thank you.
Thanks, Ronnie. The releasable sutures are, I think, a boon for all of us since we are using them. And just taking what Ronnie said further, very beautiful presentation of we have the sutures closer to the limbus and the releasable sutures away from the limbus. And when you remove the releasables, the aqueous flow is directed posteriorly, and you tend to have a posteriorly directed bleb rather than an anterior one. And what we have been recently doing in our center is a conjunctival frill incision, and not a phonics paste nor a limbus paste. And that's like a marriage of convenience between the two at 1.2 millimeters from 1.5 to 2 millimeters from the limbus. And that's also tied in a continuous fashion. And we've had enormous success with that type of a conjunctival incision, reducing the astigmatism, of the bleb, and thank you. So I think the next speaker is for LASIK. Is that Gopal for LASIK one is now for medical management and target IOP by Dr. Subhatra. till Subhatra has the slides on. Ronnie, are you still there?
I'm here.
Yeah. How many times have you had windshield wiper with the type of Kolker's modification which you are using? Have you ever had windshield wiper syndrome?
I've been doing this for almost 5 years now. I've had maybe once when the suture came loose, I had a windshield wiper. Otherwise, no.
In the different modification, Richard Wilson, and everybody has their own this thing. But windshield wiper can be a problem. But with Kolker modification, as Ronnie says, it's very, very infrequent.
And if you take both bites very close to each other, both the corneal bites very close to each other, you hardly have a problem.
One more question, which is very commonly seen: if the patient doesn't come back for releasable suture removal in the first month, what do you do?
Yeah, so sometimes, especially if you have used mitomycin, you do get away with managing to release a releasable even a little late. You have to be careful releasing it, because then you have to just use gentle to and fro movements to pull it out. If you just try and pulling it out straight off, it just breaks. If that doesn't work, you can do an argon laser suture lysis and see. Most of the time, after 1 month, you may not be successful. If antimetabolites have not been used, you won't be successful. With antimetabolites, it's a 50-50 chance that it might work.
Yeah. But if the patient does come back with a releasable suture in situ after 1 month, I would prefer to still release it, because the suture itself can cause problem. It may not be effective anymore in doing the function, but I would still remove it.
Yes, we trim the edge anyway, even if we don't release it.
Dr. Subhadra, you can start your talk.
Yeah. Can you hear me clearly?
Yes.
So my topic of discussion will be target IOP and medical management.
There is an echo. There is an echo. Is the two audios on in your place?
As we all know, glaucoma is a chronic optic neuropathy, and the pathogenesis is not due to increased intraocular pressure, which was thought earlier. But IOP is a major risk factor, and it's only modifiable risk factor. So the normal IOP in many studies have proven to be the upper limit of normal to be 21 millimeter of mercury, which is 2 standard deviation above the mean. But there is the distribution is skewed, and there is statistical constraint with inherent variability within them. And the normal intraocular pressure varies depending upon the race and age, which can be seen through various studies done in various parts of the country and world. So the goal of glaucoma therapy is to slow the rate of retinal ganglion cell loss. Correct treatment at the right time helps to reduce the rate of retinal ganglion cell loss. What is the correlation between intraocular pressure and glaucoma? There are many studies which has analyzed the relationship. For example, in Baltimore Eye Survey study, the intraocular pressure patients with more than 30 millimeter of mercury, there was 38 times more risk to have glaucoma than patients with intraocular pressure less than 15 millimeter of mercury. Even in the yearly manifest glaucoma trial, it was found that 1 millimeter mercury drop in intraocular pressure has 10% reduction in the risk of glaucomatous progression. The normal tension glaucoma also, the reduction of intraocular pressure of 30%, the patient showed less likeliness to progress in cupping and the visual field. So the treating the intraocular pressure and decreasing the intraocular pressure has become the mainstay of treatment now. It is important to set the target intraocular pressure for our treatment modality. There are many ophthalmic society giving a definition for the target intraocular pressure. So it is an upper limit of intraocular pressure adequate to delay the pressure-induced glaucomatous optic nerve damage. It has to help to maintain the functional vision throughout the patient's lifetime, and it is useful in defining our therapy goals. Let us see with an example how to set a target IOP. There is a 2 case scenarios with the 2 patients presenting with the baseline intraocular pressure of same value for around 24 millimeter of mercury. In the first case scenario, it is a 70-year-old male with no family history of glaucoma with a normal central corneal thickness, and the disc changes shows an inferior notching with RNFL defect and a corresponding visual field defect showing a superior nasal depression. And in the case 2, it is a younger patient of 50-year-old male with a family history of glaucoma in a sibling and thin corneas of 480 micron, and it is showing advanced cupping with an advanced field defect. So both the patient presenting with the same baseline, will the target pressure will be same? What are the parameters to consider for target intraocular pressure or optic nerve head changes, intraocular pressure, the severity of visual field defects, age, family history, corneal thickness, pseudoexfoliation, and most importantly, the systemic illness of the patient should also be considered. The staging of the glaucoma damage is important before we set our target intraocular pressure. And my previous speakers have beautifully elaborated how to stage the glaucomatous damage. For example, in the advanced glaucoma, the cup disc ratio of more than 0.9 and visual field defect within the 10 degree of fixation should be of concern. There are many methods to set our target intraocular pressure, like threshold or absolute cutoff value, percentage reduction, formula-based values. The threshold or absolute values of target intraocular pressure are those where there is a relatively fixed and can be applied to a large number of patients having a similar degree of glaucomatous damage. It is not much of individualized setting of target intraocular pressure, but it is our setting. For example, in case of mild glaucoma, the threshold level can be around 18 millimeter of mercury, in moderate 15 millimeter of mercury, and severe 12 millimeter of mercury. The common practice we have the percentage reduction, the percentage of intraocular pressure to be reduced from the baseline. According to the AO guidelines, in mild damage, it can be around 20 to 30%, and advanced damage, it can be up to 40% from the baseline. Even in normal tension glaucoma, a 30% reduction from the baseline will be helpful. There are many formulas to help us to achieve our target intraocular pressure. For example, in Jampel formula, the target intraocular pressure is calculated from the initial baseline intraocular pressure and with an Z score. The Z score is grading the severity of glaucoma in a range from 0 to 7. So for practical easiness, we have graded from yearly glaucoma a target set of 15 to 17 millimeter of mercury, moderate 12 to 15 millimeter of mercury, and severe 10 to 12 millimeter of mercury will help to achieve our goal of reduction in the progression of glaucoma. So as a rule, we can set a target intraocular pressure at a higher range, like higher teens, if the presentation has a higher intraocular pressure at baseline or shorter life expectancy as in old age or yearly glaucoma. And we need a lower target intraocular pressure like low teens in case of low intraocular pressure at presentation, and then in case of longer life expectancy as young patient or advanced glaucomatous damage. The limitations of setting the target intraocular pressures or diurnal physiological variations, corneal thickness and hysteresis, which can confound our intraocular pressure measurements. In spite of achieving the target intraocular pressure, a few patients shows progression of the disease also. So we have to reset our target intraocular pressure accordingly. So the practical considerations for setting the target under intraocular pressure, always set as a range rather than a fixed number, and do not promise a fixed number to the patient always, because they will be fixed on that number. And target intraocular pressure is not a static thing, it is a dynamic process. So we have to change according to the progression of glaucoma. In target intraocular pressure, while setting is weigh the benefit and risk of the treatment. So the goal is not to achieve the target intraocular pressure, but is to keep the patient seeing well enough throughout without compromising the quality of life. So completed one task. So coming to our example again, the case scenarios which we have discussed before, what can be the intraocular pressure in case 1? First case scenario, an old 70-year-old male with normal thickness of cornea and yearly glaucomatous damage, our intraocular pressure can be around a range of 15 to 17 millimeter of mercury. While in case 2 scenario, where the young patients with a family history and thin corneas and advanced glaucoma, our treatment modality should be little vigorous, and an intraocular pressure of low range will be helpful to prevent vision loss of such patients. So finishing our one task of setting the intraocular pressure, how to manage with this patient. Most of the patient, we start with the medical management to reduce the progression of the disease. Anti-glaucoma medication have gone through changes through more than a century. The most commonly used group of drug now are mainly the 5 groups of drug are cholinergic agonist, adrenergic agonist, beta blockers, carbonic anhydrase inhibitor, and prostaglandin analogs. The mechanism of action of these drugs are mainly through decreasing aqueous humor formation as seen in beta blockers, carbonic anhydrase inhibitors, and alpha agonist, or increasing uveoscleral outflow as in prostaglandin agonist, or increasing trabecular meshwork outflow, which is seen in cholinergic agonist. The percentage of IOP lowering effect differs slightly from each drug, and the maximum is seen in oral stazolamide, oral carbonic anhydrase inhibitors of 40%. Among the topical drugs, the prostaglandins plays an important role. As much as 35% reduction in IOP has been seen. Beta blockers and alpha agonists have almost same range of intraocular pressure reduction of around 20 to 25%. Brief about each group of drug. So I'll be covering mainly the important points of each group of drug because of the limit of timing. The prostaglandin analogs most commonly used molecules are bimatoprost, travoprost, and latanoprost. Because of its effective reduction of intraocular pressure of 20 to 35% and once daily application, it is the drug of choice in many cases. It has a good control of diurnal fluctuation, so best effective in normal tension glaucoma also. And it has nil systemic side effects. But it has its own drawback of ocular side effects like conjunctival hyperemia, increased pigmentation, conjunctival fibrosis, which may hamper our post-surgical effects. This conjunctival hyperemia is seen more in bimatoprost and less in latanoprost. So nowadays, latanoprost has become the drug of choice rather than bimatoprost. Beta blockers, it can be non-selective or selective beta-1 blocker. The most commonly used non-selective blocker is timolol, which can be used in the percentage of 0.25 or 0.5 twice a day or once a day. Timolol has less effective at night time because aqueous production decreases in the night. So if you choose for once a day dose, prefer it in the morning. The side effect of beta blocker is more of systemic than ocular side effects, and it is contraindicated in case of bradycardia, second or third degree AV block, active bronchoconstricting diseases. The betoxetol, which is a beta-1 selective antagonist, which is relatively safer in patients with pulmonary disease, but use it in caution in case of severe lung disease. Alpha-2 adrenergic agonist, most commonly used molecule nowadays is brimonidine. It comes with a percentage of 0.2% or 0.1%, and maximum effect is seen in used TDS of thrice a day. Brimonidine has an additional property of neuroprotection and increased uveoscleral outflow. But it is better to avoid the drug in children as it is a lipophilic drug. It can cross blood-brain barrier and may lead to hypotension and apnea. The most dreaded complication of the brimonidine is the ocular side effects like follicular conjunctivitis, which may hamper the effect of it and causes non-compliance for the patient. And even systemic side effects like dry mouth, fatigue, and drowsiness are also common. Carbonic anhydrase inhibitors, the oral molecule commonly used is acetazolamide, which comes with the dosage of 250 milligram or 500 milligram as sustained release capsules. Topical can be dorzolamide or benzolamide, and it can be used twice a day. It is a sulfonamide derivative, so use it with caution in case of and avoid it the oral medication in case of sulfur allergy, and use it in caution in case of renal diseases. The oral carbonic anhydrase inhibitor has more systemic side effects like increased urinary retention, paresthesia, metabolic acidosis, while topical has more ocular side effects like stinging sensation and blurring of vision. The cholinergic agents, which is the oldest of the drug, the most commonly used is pilocarpine, 1%, 2%, or 4%. Its mechanism of action is increased trabecular meshwork outflow by causing contraction of the longitudinal ciliary muscles. But nowadays, we restrict its usage only prior York because of its many side effects. Even in primary open angle and closed angle glaucoma, it may cause paradoxical pupillary block by relaxing the zonules and causing forward push of the lens. And some other side effects like a headache, myopia, and even retinal detachment has been documented with the drug. Hyperosmotic agents, mainly the oral glycerol or intravenous mannitol, are mainly used for the immediate reduction of intraocular pressure in cases of acute cases. The mechanism of action is mainly by increasing the osmolality, and also it has actions on hypothalamic osmoreceptors. The IV mental can be used at a dose of 1 to 1.5 gram per kilogram of 20% solution over 15 to 20 minutes. But it is almost contraindicated in cases of renal, cardiac, and hepatic diseases. The washout period of each drug is important. As we can see, the beta blockers and the prostaglandin have a maximum of around 5 to 6 weeks. This is important when we are considering switching of drug from one group to another, because we should consider the washout period to assess the effect of the other drug. So now comes the biggest question: which drug to start? The ideal drug should be suitable for daily use, and it should be effective with minimal side effects, so it can give a good compliance for the patient and long-term safety and affordability. So most commonly, the preferred first-line drug is prostaglandin or beta blockers because of its effective reduction of intraocular pressure and acceptability of the patients. So once the drug is started, assess the patient after 2 to 3 weeks. If the desired response is not achieved, it is better to switch the drug rather than adding the drug. But in cases of advanced glaucoma and severe raised intraocular pressure, it is better to add a drug. So the second line of drug usually we prefer is alpha agonist or carbonic anhydrase inhibitor. With a maximum medical therapy, the target IOP, or if we realize the progression of glaucoma is progressing very fast, we can switch to other modes of treatment like laser or surgical modalities. Nowadays, we prefer a fixed drug combinations because of its convenience of less dosing, improves the compliance and less side effects due to preservatives, and thus improve the quality of life for the patients. Few words about the newer drugs in the market. So now we have a new drug in India is a Ripasidil, which is a ROCK inhibitor, Rho kinase protein kinase inhibitor. It comes with a dosage of 0.4% twice daily. Its mode of action is mainly through increasing trabecular meshwork outflow. This is another drug other than cholinergics, which acts on the trabecular meshwork outflow by acting on the cytoskeleton contractile tissues of trabecular meshwork. It has additional neuroprotection also, which by increasing the ocular blood flow. And it has been found that it prevents scarring post-glaucoma surgery. But the most dreaded adverse effects is increased conjunctival hyperemia with this drug. Some of the other newer drugs on trial are Roprisa, which is Netasudil, which is also a Rho kinase inhibitor, but it has an additional action on decreasing the aqueous humor formation. And one other drug of importance is lacnoprostone butynate, which is a nitric oxide donating prostaglandin. It has a dual action on both uveoscleral outflow and trabecular meshwork outflow. But all these drugs are in trial, and its long-term effect are yet to be known. In future, our anti-glaucoma medication should more focus on the drugs acting on the retinal ganglion cells rather than reducing the intraocular pressure. In the currently available drugs, some neuroprotective effect has been found in brimonidine and also betoxolone. Other drugs like NMDA receptor antagonists, calcium channel blockers, neurotropic factors are all in the trial. So the practical aspects for treating a patient, as a doctor, our Hippocratic oath is primum non cere, first do no harm. So select drug with less adverse effect, which is compatible with the patient's systemic status and lifestyle. Select minimal drug to achieve the maximum myopia. It is rather to switch a drug rather than add a drug in the first place, and use a fixed combination whenever necessary to enhance the compliance. Thank you. I thank all my mentors and colleagues in Arvind Eye Institute for always stimulating me and motivating me.
Thank you, Dr. Subhadra. Would Andrew want to comment on this? Andrew?
Sorry, I cannot hear you, ma'am.
Dr. Andrew Braganza want to comment on this? He's my co-moderator.
Well, we are running. Yeah, we are running pretty short of time, so we'll try and restrict comments. But I think she's given us a wonderful overview.
Come back to the discussion if time permits.
Yes, yeah, that's right.
Okay. So you can probably invite the next speaker, Dr. Kirti.
Yeah, thank you. Am I visible?
Very much.
Yes, ma'am.
And audible?
Yes.
Okay. All right. So first of all, at the outset, thanks to Cochin Ophthalmic Club for having me here and Dr. Pillai, and for a very wonderful, enriching experience. I am learning so much. Great initiative. So I'll just come with the trabeculectomy journey, managing a bleb misbehavior. Now, glaucoma and cataract differ basically in many things. One, cataract surgery, when you are done with, you know you are done well, and the patient also will know you've done well the next day. Whereas glaucoma surgery, even if you've done very well, as Ronnie said, it's very unforgiving and unpredictable. So glaucoma surgery is a successful trabeculectomy, is a battle well fought, but the war can and still lingers in the many bends and curves. So the mantra to ensure bleb survival is, for Harry Potter fans, constant vigilance, in the words of Moody. Milestones in the bleb journey. In the first 3 days, you will come to know whether this trab is going to fail or pass. And the 3 criteria for failing or passing are the bleb morphology, the AC depth, and the intraocular pressure. If the bleb morphology is shallow and the IOP is high, it's probably a tight suturing. And if the IOP is low, it could be a leak. If the AC depth is shallow and the IOP is high, it could be a blocked PI. And that's where Ronnie very nicely said that your PI should be larger than the ostium, or it could be an aqueous misdirection. If the IOP is low and the AC is shallow, it's overfiltering or coral attachment. Deep with the IOP high, it could be that you've left some viscoelastic in the chamber. In trabs also, at least I use viscoelastic, or it could be a blocked sclerostomy. By first week, when the patient comes back to you at 7 days, if your bleb will tell you it's going to pass with distinction or not. Again, morphology, IOP, and depth. Early fibrosis can be picked up at this stage, and tight suturing can be diagnosed. First fortnight, if your bleb goes well, that means you have almost gone through with honors. And at this stage, you will start using your technique of removing releasables and deciding when to remove releasables or to leave them. Having said that, early fibrosis can set in, tenon cysts can appear, and you have to monitor for that. First month, if your bleb is doing fine, your sutures are all removed, and the morphology is good, you will know that this bleb is going to weigh. So first month is very critical. That is what I try to highlight in this milestones. So let's come to the 3 aspects of bleb I'll be covering. First is a bleb leak. The risk of bleb leak is maximum in the first 5 years, and moment you use mitomycin C, it will worsen. first treatment of a bleb leak is pad bandage and aqueous suppressants. You will use Dimox to suppress the aqueous. Secondly, you can do a torpedo bandage, or you can do a resuturing or a tissue glue. If that fails, a amniotic membrane resurfacing, and if that also fails, a patch graft and a Momini's repair. So go step by step. If it's a bleb leak, first of all, it's conservative, but for diagnosis, there's nothing like a Seedles to tell you that this bleb is leaking, as this video shows you. How to suspect a bleb leak? AC will be shallow, IOP will be low, and the bleb will be shallow. So this is the way we handle it. The AC is shallow. Okay, there's Descemet's folds also here, and I've just used systemic acetazolamide, put atropine, or you can use midricaine also, injection midricaine, which is nothing but xylocaine, phenylephrine, and atropine mixed, and use a torpedo bandage. In a torpedo bandage, you just make a bolster of cotton, make the patient look down, make a bolster, and put another pad, and then bandage the eye for 24 hours. And very often this just works, and in this patient sequentially it works. If this doesn't work and the bleb leak persists, and this, as in this case of eye rubbing, which it persisted, I've done a bleb anchoring suture and then a torpedo bandage. So suturing plus torpedo can be used. This patient unfortunately had a lot of conjunctival inflammation. A lot of these patients are on anti-glaucoma medication for a long time, and their conjunctiva has subclinical inflammation and is unhealthy and doesn't heal that well. So for these patients, you need to be extra cautious, especially when you're using mitomycin C, because that makes the conjunctiva even more fragile and vulnerable. So this patient required a quilting with an amniotic membrane cover. I used quilting sutures, and this amniotic membrane had to be left in position for 2 to 3 days as to bandage the eye, open it, and then rebandage it. So within 10 days, the AC started forming, and we could get away in this patient without doing another procedure. The other option, third option, is in a shallow AC with a large leak is tissue glue and anchoring sutures. Last option is a very interesting technique called as Momini's repair. Now this was a very old bleb which was leaking persistently. The AC wasn't that shallow, but this type of a bleb is a time bomb. So here you just do a conjunctival dissection around it. Take a half thickness scleral flap from distal to the bleb and evert it, and then just anchor this at the sides of the existing bleb. You aren't touching the bleb at all, and you're just covering it with the sclera of the patient, and the conjunctiva is again sealed back. So this has saved many a bleb for us by the simple technique of Momini's repair. Here I used amniotic membrane for resurfacing. It always is not an antifibrotic. It's a very good resurfacing or a scaffolding medium too. Now to prevent this bleb leak is the best. For any problem, the prevention is best. So bleb anchoring suture, as Dr. Ronnie said, horizontal mattress or the wing sutures, and titration at the end to know that there is no bleb leak. And this is the technique of anchoring sutures. Sorry. Sorry. This has been given very well in the CME series, which was published by us way back in 2007, and anybody who's interested can look at these. Next aspect I'll be covering is the overfiltering bleb. Again, the treatment remains similar to leaking bleb in a way that cycloplegics are used. Midricaine can be used, torpedo bandage. However, in this, you reduce the frequency of steroids so that you permit subconch fibrosis to happen. Rule out lens displacement. We very often have angle closure glaucoma patients with a bulky lens, and if the lens zonules have been damaged during trabeculectomy, this displaced lens can also mimic an overfiltering bleb by causing shallow AC, and the bleb is high. and lens management is the one which would treat this overfiltering bleb. However, that's not a very common cause. So the most common cause is overfiltering. Delay the removal of releasable sutures till beyond 6 weeks, because by that time the effect of releasable removing will be lost. And if hypotonous maculopathy is developing or Descemet's folds are there, only then you intervene. Otherwise, overfiltering bleb, you just let it be. It will resolve with time if you reduce the frequency of steroids. However, if these complications of hypotonous maculopathy or Descemet's folds are occurring, then you can use any of the three options of compression sutures, autologous bleb injection, or SF6 gas injection. Just a minute, my scene has sorry for the glitch, it stopped in between. Is it visible?
Yes, ma'am, it's seen.
Okay, so this is an overfiltering bleb. Okay, your AC depth is shallow, and first option is just conservative wait and watch, cycloplegics, atropine, midricaine, torpedo bandage like I showed you before. If it doesn't work, then you go ahead and do this autologous blood injection along with compression sutures or without the compression sutures. Now this blood is withdrawn from the antecubital vein of the patient, and the syringe is not changed, the needle is changed, and if you can see, this bleb was thin and this leaking has occurred here. So you inject the blood very fast before it has coagulated, and in this patient we needed to do a suturing along with it because it was a thin bleb. Here I'm also using compression sutures. Compression sutures are 2 to 3 sutures are given, preferably nylon because they are thicker, and you just compress, pass it through the subconjunctival space and the tenons and tie it with the knot buried. And again, the patient is put on cycloplegics and antibiotics, no steroids, and monitored for at least a week. So this is the compression sutures and amniotic membrane position. Another patient with compression sutures, it very often works, but it's not always, it doesn't work always. The last option is if you have the Descemet's folds persist and there's overfiltering bleb, you can just inject SF6. It temporarily blocks the ostium, causes the cornea to reform its shape, and the IOP will be transiently increased. However, having said that, many of these patients have advanced glaucoma, so you have to monitor the IOP increase because you can have a snuff out phenomena. This was a case I was showing you, that the broken releasables and a lens subluxation which caused an overfiltering bleb. Next topic would be the sick bleb or the impending failure. Here the bleb height would reduce. IOP could be high, it could be normal, or it could be low. Most common causes of bleb failure are two types: external, which is due to subconjunctival fibrosis. Here you can see the ring of steel with the limbal base flap, and here you can see an overall fibrosis. Uncommonly, it's an internal ostium closure, so that causes internal closure where the sclerostomy is closed by iris, blood clot, or fibrin. To revive the bleb, the acronym is the CAB. How you revive a patient, resuscitation of patient. First is rule out an internal blockage. So for that, gonioscopy is important. And after gonioscopy, you rule out internal blockage. The first thing you do in reviving a bleb is a very simple procedure called as the bleb massage. There are many ways of doing a bleb massage. The one I prefer is from inferiorly. And you ask the patient to look up and massage the bleb. And you teach the patient or the caregiver to do this bleb massage at least 3 to 4 times a day, and the bleb very frequently forms. Another clue is for failure. Do you wait for a failure by waiting for the IOP to rise? You intervene before that. So the first clue for failure is the bleb morphology. It will flatten. The bleb will flatten. So the message here is to prevent bleb failure, do not wait for IOP to rise. Moment the bleb flattens over time, you anticipate failure and start treatment. So next revival technique is when the bleb is shallowing, you go ahead and release the releasable suture. This is a technique I follow for releasable suture, the Wilson's technique. And on the slit lamp, I just cut the releasable suture and remove it, and the bleb forms. Sequentially remove the releasable suture 1 and 2 within a period of 10 days. Never remove both sutures together. Give a gap of minimum 3 days, preferably 7 days before you release the 2 sutures. Other signs of failing bleb, one was shallowing of the bleb. Other signs can be a tenon cyst happening, walling off of the bleb, reduction in the height or extent of the bleb. Vessels will give you a good sign. Increased vascularity, these corkscrewing or even straightening of vessels, and when you move the bleb, stiffening of the blood vessels. IOP may or may not be raised in the initial stages of a failing bleb. Blebs invariably do fail, and trabeculectomy success reduces by 50 to 60% over 5 years. Subcutaneous fibrosis is the commonest culprit. The propensity is more in pigmented races. Therefore, scarred blebs are frequent in our Indian context, which because we are brown raced. Needling is a procedure which is very simple, which attempts to revive these blebs by lysing the fibrosis engulfing the bleb. In our center, we have a very good success rate, and this is how we do the needling. I call it the CPR of a bleb. When you decide to do the needling is within the first 4 to 6 weeks, you can do it that time. That's an early needling. After you've managed the bleb failure by sequential removal of releasable suture and bleb massage, if that fails, you go ahead for needling. You can do it on an intermediate phase within 12 months, and even after late failure, we have done a needling for a patient of 9 years post-trab and revived the bleb. It's an extraocular procedure on the operating room or the slit lamp. I prefer OR. Under topical anesthesia is sufficient. If you're doing an internal procedure with it, which I just described, in that case, you need a peribulbar anesthesia. I use a 26 gauge needle. Advisable is 27 gauge, but I find 27 gauge to be too pliable. So 26 gauge works. I always use needling combined with 5-FU or mitomycin C. And this is the video of how a needling is done. This is the 26 gauge needle. I've entered away from the bleb, and with sideways or jackhammer movements, I'm lysing the fibrotic lining or the walling off of the bleb. In between, I'm ballooning the conjunctiva with mitomycin and 5-FU. You can actually feel the gritty feel when you're cutting the fibrotic bands. At all times, try to keep the needle visible and use 5-FU and MMC simultaneously. You can see it's an avascular bleb, and yet it is fibrosed and it is not working. When you exit at this point, you inject viscoelastic to wall off the 5-FU and mitomycin so that it doesn't diffuse out. As I said, always do a gonioscopy to rule out internal closure, because if you are doing needle without checking the internal closure, you are going to land up into failure again. If it's internal closure, your PI very often becomes invisible because the iris is plugging the sclerostomy, and gonioscopy is important to diagnose this condition. This is the patient in which we have devised a procedure called as internal revision. It's such not devised by us, but is revived by us. It has been described previously. When sclerostomy is blocked by iris, what you do is something like a Heimlich's maneuver. You just remove the iris from that area. And this is how we do it. In this, it's a procedure under peribulbar anesthesia. I'm sweeping out the iris after inflating the anterior chamber with viscoelastic. And from here, from the internal ostium, I'm removing the adhesions. Okay, so I'm going beneath the superficial scleral flap. After you've removed all the adhesions and the PI has been formed, remove the viscoelastic and titrate the entry point. Hydrate the entry point. Now you combine this. Always internal bleb needling is combined with external needling, because once aqueous has stopped flowing in the bleb due to internal ostium closure, bleb fibrosis has supervened. So it always has to be combined with a external needling procedure. So same way as I showed you previously, you seal the entry with viscoelastic to prevent egress of MMC and patch the patient for 24 hours. This is another patient. Can the admin people remove the audio? I'm unable to do it at this end.
The admin people are enjoying the music.
We want the full song, Kirti. Okay.
Okay. Yeah, okay, be sure. This technique of putting visco at the end prevents exudation of mito or 5FU, and touch wood, I haven't had any corneal complication with 5FU or mitomycin since I used this procedure. So these are, and you'll be surprised or not, we have more than 150 odd patients now whom we've revived the blebs by just needling. And incidentally, this video of this presentation of ours got the first prize award at the last AIOS. So this is a block sclerostomy and the open sclerostomy after internal revision. And this is just one case, Vinit, of a pre-revision bleb. You can see the avascular bleb and this walling off, and post-needling, post-revised revision, the bleb is more diffuse. This was a patient actually where the internal ostium was closed, the IOP was 24 and dropped to 15, and the bleb morphology improved. So just concluding that post-operative regimen after the bleb needling is topical antibiotic steroid combination. QID for 2 to 3 weeks is sufficient, rarely for 4 weeks. You can start the bleb massage from 3rd day onwards. As I said, timing can be as early as 3 months to as late as 7 years. This is as per literature. We have done a 9-year patient also. You can repeat the needling as much as 2 to 3 times. It's a very simple procedure. You can repeat it. And the success rate is almost 82%. And with ASOCT, we've documented that needling increases the microcystic blebs and the blebs start becoming functional. Last but not the least, if your blebs fail, of course, you have to repeat trabeculectomy, and that's what Ronnie was saying. If you stagger the first trab to nasal side, don't use up all the real estate. Leave space for a repeat trab, as in this patient, we required a repeat trab. Thank you for a very patient listening. I'm open to questions.
Yeah. Thank you, Dr. Kirti, for an excellent talk and nice music. Probably that जब कोई बात बिगड़ जाए, whenever you do a trap,
Yes.
things can go wrong. So that is what probably she was trying to mean. And it is actually, I think a PG should understand that we are fighting against the mighty nature. We are creating a fistula where it should not be. And our body tries to close all the unnatural openings that we create. So obviously a trap, a failed trap is not something very uncommon, keeping the mighty nature in mind. So you should always tell a patient who complains that the surgery has failed that we both are fighting against the mighty nature. So always take the patient to your side and see that. And she has given an excellent idea about how to manage whenever things go wrong, and always expect traps to overfilter or underfilter. Only one question, since we do not have much time, Kirti, only one question, short answer. Do you, between the two evils, what do you choose? Overfiltration or underfiltration?
I would prefer overfiltration because underfiltration I can manage much more easily. Overfiltration is more difficult. And last,
Okay.
I would just like to agree with KP, but we are fighting with nature. We want the conjunctiva to heal seamlessly and go with nature, despite using mitomycin. But we expect sclera not to heal and go against nature. So we are trying to, be the devil's advocate for sclera and not for conjunctiva. So yes, we are fighting against nature. And if you tell your patient that this trap I'm doing is not to improve vision and it may fail over 7 to 8 years time, so need to be my friend and come back to me because I may need to do a repeat trap.
So thank you, Dr. Kirti.
One quick question. Dr. Kiran here, madam. When you needle the bleb, you inject F5FU or MMC. I mean, right in the bleb itself. Hasn't that created any problem for you? I mean, is there a chance that the MMC or the 5FU can leak into the anterior chamber through the open ostium?
Yes, it does leak because if you are going to create the ostium, if you are going to actually want the bleb to function, you are having a passage from the anterior chamber subsclerally to the subconjunctival space. But as I said, almost now 1 decade, my residents, all my SRs and all my PGs, and we have been doing needlings. Touchwood, I've just had one case of ocular macular edema. I've had no cases till now of any problems of corneal endothelial toxicity, corneal epithelial toxicity, except for hyphema. Mild hyphema does happen, but no problems so far because we have just localized the mitomycin C to that area, and we put visco and we do it under titration. So no problems. Actually, it's a very beautiful procedure and it's a very underutilized procedure.
Yeah, I have had one patient who had a 5FU leak into the anterior chamber and coming up with a lot of reaction. Subsequently improved and all fine, but after that I've been very hesitant to, though I'll needle through the physical movements into the bleb itself, the injection is almost always away from the actual bleb.
You go away from, supposing your bleb is from, let's say from 1 o'clock to 2 o'clock, you go from the temporal side almost from 3 o'clock away, and then you enter gradually, and then by sideways movement and jackhammer movements, you just lice it and then go from the other side and again do that movement so that you are away from the bleb. So the bleb, actually the mitomycin or the 5FU is localizing itself at the wall of the bleb where it's required. However, there's a barrage, there's nothing like that. The mitomycin can't enter the anterior chamber. It does, and it should a little bit. But having said that, almost more than 300 to 400 cases, and we're publishing a data on 150 patients, we've had no problems.
Thank you.
Very much.
I think
Very much. Let's move to the next by Dr. Ebi. Dr. Ebi is consultant glaucoma surgeon at Southampton and clinical lead.
So you can note the prefix Mr. All the surgeons are called Mr. in UK. So go to and he has come very early to catch up
surgeons
with us.
of
Thank you so
London.
much.
Can you hear me?
Yeah.
Yes.
Thank you, Gopal and Andrew, for having me. I'm going to talk to you about laser in the management of glaucoma. Just a quick word about the previous discussion. I have stopped injecting on the slit lamp after I've had one case where a lovely Pakistani lady, I could see the 5FU drop into the anterior chamber, horrendous reaction after that. And that bleb failed after that because I was so inflamed. So I stopped injecting on the slit lamp after that. From then on, it was always injecting in theater. Anyway, carrying on with my talk, I'm sure all of you know that laser is an acronym, and the quantum physics is far too complicated for me to be talking about it. So what I will say is the specific effect on the particular tissue is the most important thing as far as we are concerned, and that depends on the wavelength of the light, how we deliver that energy, and of course the intrinsic properties of the target tissue. This is a grid that I usually show for most of my surgical talks. And here you can see that the laser is populating this side of the chart. PIs are there. Then there's the other group, the trabeculoplasties. Then of course the transscleral photocoagulations. But I've also added on a couple of other things here, which doesn't usually come into the surgical grid. And of this, I think the most important thing is the PRP. And I'm sure all of you have seen a lot of patients who have supposedly had PRP, but who end up with horrendous neovascular glaucoma. Lasers, ophthalmic lasers are, as per laser safety, classified as class 3B or 4. They're not 1 or 2. So what that means is that these lasers have to be used carefully. And that's the first and foremost message, especially for the juniors who are listening to us. The lasers that we use are either a continuous wave, which means that it continues to emit light steadily, or they are pulsed. Pulsed meaning the light is emitted in discrete pulses, and the advantage of this is that they can have extremely high powers. As you know, lasers work for us in 4 different ways. The things that I'm interested in are the first 2, photomechanical, which is our classic photo disruptor laser, and the photothermal, which is our classic photocoagulation lasers. Firstly, to the photo disruptors, they create access to the anterior chamber angle when we do PIs. The YAG laser is a neodymium doped solid state laser. And the big development over the years is that we have now got frequency doubling YAGs, which makes us do more than one thing with the same laser. And frequency doubling for the juniors again is a process by which 2 photons are combined to generate a new photon, which has twice the energy, by which you mean that it has twice the frequency and half the wavelength. But it maintains the coherence of the excitation, which means it's still a laser. We use, as glaucoma specialists, the YAG laser all the time. And of course, the laser peripheral iridotomy is the first and foremost thing that we use mostly. Having said that, even a posterior capsulotomy may have a role in glaucoma, and that is either as part of an anterior hyaloidotomy, or it could even save you in a capsular bag distension syndrome if all conservative measures don't work. Going on to LPI, the indications I'm sure you're all familiar with, but the laser iridotomy is, of course, the first procedure that you need to do in case there's an aqueous misdirection, which is in a case where there's no PI or no patent PI. So you have to assure yourself that there's a PI to start with before you start managing any case of aqueous misdirection. With the laser iridotomy, you're familiar with the complications. The most common thing that we are all worried about is the IOP spike. But the thing that probably bugs us all the most is when the patient walks in with a visual disturbance, and will never let us forget it. The technique, I'm sure again you're familiar with, you make the iris taut with pilocarpine drops about 15 minutes before the procedure. You can use pre-op aproclondin, and if you don't have that, you can use Diamox. The most important message, especially for someone who's learning laser iridotomies, is spending 5 minutes or 10 minutes looking for a nice little crypt is time well spent. If you don't find a crypt and you start trying to blast your way through a thick iris, you could spend a lot of time there trying to get through that iris. So spend time finding a crypt. The power depends again on the size, on the thickness of the layer of the iris. And most important thing again is that you need to check the intraocular pressure before the patient leaves the hospital. You need a reasonable size PI, and the classic appearance is the plume that comes out when you get through. You may have to sometimes continue the miotic in some patients. This is a good picture. It's an old picture. Most of us have moved on to OCTs, but this is a UBM. You can see the angle closure nicely here. Post-laser iridotomy, classic feature. This iris is now ramrod straight. So if you see an iris straight like this in any patient in an anterior segment OCT, you can rest assured that the PI is somewhere there. So you need to find it. The other procedure which I use once in a while for with a YAG laser is to use it for a goniopuncture in deep sclerectomies. And you can see here that the iris, the trabecular descemes window is disrupted using the laser. Over here, this one is not a great picture. And this one, again, you can see the disruption. What I would suggest here is that if you're doing a YAG laser goniopuncture, these are not my pictures, this is from Medscape. You should try and do it at the anterior edge. If you do it posteriorly, there will always be a tendency for the iris to show its presence. And you don't want that. In fact, if the flow is high, you can have the iris coming in and filling up the whole scleral lake. Hyaloidotomy is a very good procedure to buy you time in aqueous misdirection or malignant glaucoma. In pseudophakics or aphakics, you can go through the pupil, but in patients who are phakic, you might have to go to the peripheral iridotomy. What you need to use is a posterior offset in these patients, and the power can be high, but there's always the risk of retinal complications in these cases. But it will buy you time. It may not be the definitive answer to your problem. You might have to deal with it surgically, but it will get you some time, at least. Moving on to the next lot of lasers, and that is the laser trabeculoplasty group. The indications are fairly straightforward. Everyone knows about it. You can even use it in angle recession glaucoma, but you need to restrict your treatment to the non-recessed part of the angle. Of course, there are two absolute contraindications, and that is inflammatory and neovascular glaucoma. There's no point in trying to do it in these patients. You can do trabeculoplasties in angle closure glaucoma if you have opened up the angle. So if the patient is pseudophakic, there's no reason, and you have opened up the angle, there's no reason why you can't offer that patient laser trabeculoplasty. There are three lasers that have been used for this mainly. Argon laser trabeculoplasty used to be the laser of choice till selective laser trabeculoplasty came along. The big advantage with selective laser trabeculoplasty is that it causes less side effect, less complications. And the main complication with argon laser trabeculoplasty, one it being a destructive sort of a laser in that you're causing some damage to create the effect. And the second most important thing we as glaucoma surgeons hate to see is synechia. Micropulse laser trabeculoplasty is a new modality that is available with the Iridex laser, but I'm not familiar with it, and there are not too many good papers in the literature as well with regards to this. Comparing the two, the ALT is a much smaller sized laser beam, and it has to be placed in the anterior half of the trabecular meshwork, as you can see in this picture down below. The SLT is more forgiving, especially if you are having a junior doing your laser for you. He or she needn't be totally familiar with the structures of the angle, because it's a large beam. It's very difficult to miss the trabecular meshwork using this laser. This is what happens with selective laser trabeculoplasty. The laser triggers, targets the melanin cells, triggers cytokine cellular mediated activity, and then the macrophages come in and clear up the debris so that you have a squeaky clean trabecular meshwork at the end of it. So in summary, the ALT works through a mechanical effect, while the SLT works through a biostimulatory effect. And this is the same thing with the MLT as well. Results between the two are fairly similar. And the SLT, which is these days the treatment of choice, can be used either as a primary therapy or as an adjunct to medical therapy, or in some cases as a replacement. Especially in patients who start getting allergic to drops and things like that, this is an option to turn to. Moving on to the next group, the argon or the diode laser or the frequency doubled laser. These are the uses of it. The laser iridoplasty, again, is another type of laser that is largely gone out of fashion, but it still may have a role in breaking an acute angle closure attack. Laser iridoplasty can also be used in cases of plateau iris, but after the EAGLE study has come out, most people would prefer to probably go and take the lens out and get into trouble that way rather than trying to do a laser iridoplasty. Finally, on to that last group of procedures, that is cyclodestructive procedures. The transscleral cyclophotocoagulation is the treatment of choice these days. It is again displaced cyclocryotherapy, which used to cause a lot of inflammation, was very painful to patients, and it also had a higher incidence of hypotony and phthisis. We tend to use the 810 nanometer diode laser, and the indications are by and large intractable and refractive glaucomas. This is also used for pain relief in a painful blind eye, and also as an urgent means to lower IOP when access to surgery is limited, like these days. COVID times, can't get a patient into theater. You want to buy some time, pressure is running sky high. Yeah, do 90 degrees of cyclodiode, and hopefully you will get another few months before you can hopefully think in terms of operating on the patient. Then, of course, it can also be used in patients who are medically unfit. The procedure is fairly straightforward. Most important thing is that if you do have a large eye, the G probe is not designed for that, and therefore you have to transilluminate the eye, see where the ciliary body is, and aim your laser appropriately. I go with all the twos. I start with 2000 MW in 2000 milliseconds, and then titrate it up or down as required. The important thing to look out for or listen to is for the pop. If the laser pops, you are at a higher power than what is required. So you either lower it by 100 or 50 megawatts, milliwatts, or you extend the time, okay? Important thing again is to avoid the 3 and 9 o'clock positions and thin sclera. Again, it's also ideal not to go through any previous surgical sites. Post-operatively, please give the patient some pain relief. NSAID and topical cycloplegics are important, and steroids. you reassess after about 4 to 6 weeks and decide whether you are going to retreat or not. Because these days, again, a lot of the patients that we do laser on are not people with no visual potential. They are quite often people with some amount of visual potential, and therefore you need to titrate your dosage appropriately. Big risk with any cyclodestructive procedure is phthisis, and you need to be watching out for it. Endoscopic cyclophotocoagulation is a very interesting concept because it only ablates the ciliary epithelium on the surface of the ciliary processes. Therefore, it's far more effective and safer than transcleral procedures, which are quite a blind procedure, actually. The good thing about it is it can be combined with cataract surgery, and there are a lot of surgeons. In fact, I've got a very good friend who is a very keen proponent of phacoemulsification with endoscopic cyclophotocoagulation. And he has got excellent results, and he has published it as well. The restricting feature is the laser unit. It's quite expensive. The probe has 3 fibers, the diode, a xenon light source, and a helium neon aiming beam. And the good thing about it is the endoscopic view, which can be seen on the video monitor. You use a limbal approach. You inflate the sulcus by injecting Helon GV under the iris, and you use a power of 0.2 to 0.5 watts in a continuous wave mode. The thing to look out for is whitening and shrinkage of the ciliary processes, and you treat the whole area, including the peaks and the troughs of the ciliary processes. Once you're finished with one side, switch hands and go finish the other side. You can treat almost 360 degrees with this procedure. If need be, you can put an extra incision in. People who do cataract surgery tend to do this by using one port as a cataract surgery port and the other one as a side port. Post-operatively, you need cycloplegia and steroids, and the steroids you may have to give some more because one of the main side effects of this procedure is fibrinous exudates and hyphema and cystoid macular edema. So you have to be on the ball with regards to the post-operative management of inflammation. On this topic, it's very important that you stop the miotics, because if you don't stop the miotics, that can in itself create more inflammation. Always bear in mind that there's a risk of endophthalmitis, and when you have a lot of fibrin or hyphema in the eye, it can get a bit murky. I think that's it. Thank you very much. That's our latest acquisition at our hospital.
Thank you, Dr. Abhi Jacob. That was excellent. And you have chipped in from Southampton and covering almost the entire array of all the laser gadgets that we have in glaucoma. Probably many more will come and fill the horizon. Thank you so much for chipping in and trying to finish it within time. So we have the last speaker of the today's session. I was
within time.
Yeah.
Very much.
Excellent. So we have Dr. George Putlan, who has been closely associated with very good surgical glaucoma practice, especially he has been involved in the evolution of the GDD, and that to the Indian avatar of glaucoma drainage device, ODI. And Dr. George Putlan is a sought after speaker, one of the well-known authorities in this field of glaucoma, especially surgical glaucoma. So we are all ears for you, Dr. George. Please go ahead. Please share your slide.
Thank you very much, Dr. Krishna Prasad. Am I audible?
Yeah, very much.
I think Abhi has to stop sharing his slides first.
Yeah. Everybody, especially to my friends at Cochin Ophthalmic Club. I'm not able to, Dr. Abhi, will you be able to
stop sharing?
I don't know what I'm doing wrong. Sorry.
We are still in Southampton.
Oh, lucky you.
Now you are in Madurai.
Have I got out?
Yeah.
Yes, you have. Okay.
Okay, sorry.
Is it seen now?
Yes.
Thank you. So the plan for the day is to go through the principle, indications, design, surgical technique, and complications of aqueous drainage implants, which would probably be a better technically more apt term than a glaucoma drainage devices. The only liberty I've taken here is to add a small video about patch-free, flap-free tube implantation, which probably will be beneficial to the glaucoma surgeons watching. So the principle of an aqueous drainage implant is to have a silicone tube in the anterior chamber or the posterior chamber that drains aqueous to an end plate which is situated at the equatorial region of the globe. So one common factor for all end plates of aqueous drainage implants are it is made up of biocompatible material to which fibroblasts cannot adhere. So many weeks after surgical implantation, probably 5 to 6 weeks after surgical implantation, a good fibrous capsule forms around the episcleral plate, and which is not adherent to the episcleral plate. So the aqueous draining through the tube potentially collects in the potential space between the end plate and the fibrous capsule, and from there by passive diffusion to the periocular capillaries. So the indications for glaucoma drainage devices are medically uncontrolled glaucoma where trabeculectomy has failed or is unlikely to succeed. So traditionally the teaching is aqueous drainage implants are generally reserved for patients with ambulatory vision, and cyclodestructive procedures are reserved for patients with very poor visual potential. Again, many secondary glaucomas, any patient who has undergone prior intraocular surgeries like post-penetrating keratoplasty, post-vitreoretinal surgeries, presence of bands, silicone oil, these are all good candidates for glaucoma drainage implant surgery. Again, a whole lot of secondary glaucomas like neovascular, uveitic, fibrous epithelial ingrowth, iridocorneal endothelial syndrome. Again, for children with congenital glaucoma who have failed angle surgery and or failed trabeculectomy, these are good procedures of choice. Again, developmental glaucomas with ocular anomalies like accent field rigor, aniridia, and there are two groups of patients who potentially fit into this spectrum of trabeculectomy unlikely to succeed. These are those glaucomas associated with elevated episcleral venous pressure like the ocular phecomatosis, the Sturge-Weber, and also glaucoma in aphakia, especially children, glaucoma in children who have undergone congenital cataract surgery. So these two groups, potentially the operative complications, the risks of operative complications are quite high due to the risk of suprachoroidal hemorrhage that glaucoma surgeons generally tend to position glaucoma drainage devices as the primary procedure of choice in these two group of patients. Coming to implant designs, they differ with respect to the size, shape, and material from which the end plate is made, and also depending on whether you have a valve mechanism that prevents aqueous to flow through the tube. When your intraocular pressure goes too low, you can classify these implants into valved and non-valved implants. So the Ahmed glaucoma valve prototype valved implant made of the ones that we now commonly use are all made of silicone material. FP7 has a larger surface area, the 184 millimeter square. The FP8 is a smaller surface area, 96 millimeter square. The latest is the M4 plate, which is made of porous polyethylene, and everything has this valve mechanism. These are made of silicone elastoma membranes that separates with an IOP of 8 to 12 millimeters of mercury. And postgraduates also need to know that Krupin valve with disc is also a valved implant. So the Barwell glaucoma implant and the Orolab aqueous drainage implant are non-valved implants made of barium impregnated silicone. Both of them have models with 350 millimeter square surface area episcleral plate, and the Barwell also has the smaller version, which is the 250 millimeter square. So what the advantage of having this Barwell glaucoma, the design of this Barwell glaucoma implant, you have a larger surface area implant that could be implanted in a single quadrant, and the episcleral plate is the surface area is much larger, and you have a capsule that is a much larger surface area and a thinner, and they predispose to potentially much lesser intraocular pressure. Again, Molteno round plates with polypropylene pediatric single plate, double plates available. Double plates are connected by a 10 millimeter silicone tube with one of the plates positioned underneath or above the superior rectus muscle. Surgical technique similar irrespective of the type of implant. The difference is with respect to the size of conjunctival incision. Larger surface area implant will naturally require a larger conjunctival incision. And the most important difference is that you need to temporarily restrict the flow of aqueous till that good fibrous capsule is formed around the episcleral plate. That's probably 5 to 6 weeks post-operatively. Another difference is AGV implant would require a priming. You need to inject balance salt solution through the tube using a 27 gauge cannula to put in flow the patented Venturi flow technology. And for the Bowel and the Orolab aqueous drainage implants, the lateral wings have to be positioned beneath adjacent rectus muscles. And most surgeons prefer to have their episcleral plates in the supratemporal quadrant, which means the lateral wings are positioned underneath the superior rectus and the medial rectus muscle. Again, this is important for non-valved implants. We use 6-0 vicryl to completely close the tube intraoperatively, watertight closure, and potentially after 5 to 6 weeks, this tube lysis and the tube patency is re-established. Again, the tube is trimmed to an appropriate length of to get about 2 millimeter of tube in the anterior chamber, and it is guided through a 23 gauge scleral track into the anterior chamber, iris plane parallel as far away from the endothelium as possible. We also use patch grafts to cover the anterior part of the tube to minimize the risk of tube exposure. As with any intraocular surgery, meticulous closure of tenons and conjunctiva is advisable even for glaucoma drainage implant surgery. So this is something I thought the glaucoma surgeons would be watching would be interested to try. The tube is trimmed at about 2 millimeter, draped over the cornea. A 2 millimeter and anterior bevel is fashioned. Then 4 millimeter, we aim to get about 4 millimeter of scleral track. Everything is measured. You use a Castroveggio caliper and a sterile marking pen, and the initial groove is made 2 millimeters medial to the original position of the tube. This could be either the right eye or the left eye, but the initial track is initiated medial to the original position of the tube. And then the track is initiated with a bent 23 gauge needle, and we get into about 50% of depth of the scleral. We aim to have it at 50% of the depth of the scleral track, shown by the visibility of the needle throughout the track. And there is a prejudged position at the limbus where the tunnel track has to dramatically change from a tunneling motion to a direct dip into the anterior chamber. So here a little bit of counter traction is applied to get the eyeball looking straight up rather than a relatively downward position. And so that you also see the tube, you see the needle in the anterior chamber, iris plane parallel. And very carefully, this needle will have to be removed in the very same track, and to make sure that this track is intact and it's of a 23 gauge. So then, as for your normal implantation of the tube, it is guided through the tunnel track into the anterior chamber. So there's always this common question among glaucoma surgeons: what do we do if we don't have access to patch material? And many of glaucoma surgeons have also tried raising scleral flaps, just like your trabeculectomy flaps, 4 into 4 millimeter flaps, to surmount the fact that they may not be able to get access to your patch material. So you find about 2 millimeter and it's the initial sinuous track. We don't patch these eyes. We don't use patch material for these eyes. So this is slightly more than 4, but a minimum of 4 is required. And tenons and conjunctiva is very carefully repositioned back. So we have our results published. For those of you who are interested recently in the AJO, and we have tried to describe the surgical technique as best as possible with some crucial practical tips thrown in. Also, we have also tried to address why tube exposures are of paramount importance when you try to implant an aqueous drainage implant without patch material. And this is precisely the reason why this technique of not using patch graft has not been studied much in literature. But we have tried to explain this in detail in this publication, and it would be good to go for those of you who would be interested to try this, to go through this, because the important caveat is to have your tube embedded in the patient's own sclera of an adequate length and depth, and this minimizes tube exposures. Postgraduates should also know that sulcus placement of tubes is preferred, especially in post-penetrating keratoplasty eyes, where there is a lot of anterior PAs, and this maximizes the distance of the tube from the endothelium. And you also should know that pars plana tube insertion is an option when there is not enough adequate space in the anterior chamber, and also when you are planning a procedure along with concomitant vitreoretinal surgery, as we do with certain situations like silicone oil removal where there is refractory glaucoma. Another option, another indication for a pars plana tube insertion is probably very significant scarring at the limbus, a lot of previous surgeries. Coming to the last part, complications, early postoperative hypotony, and see, this hypotony-related complications like shallow anterior chambers and choroidal effusions are common with drainage implant surgery. Most of them resolved with just observation and medical treatment. Choroidal effusions also resolve almost always with medical treatment, but indications for drainage of choroidal effusions are when they are 360-degree kissing and when there is lenticular corneal touch. Tube blockages in the early postoperative period can occur with materials like blood, with tissue with blood, fibrin, both of which will resolve spontaneously. But vitreous iris or silicone oil which blocks tube will have to be surgically removed. Tube retractions, especially seen in pediatric children, there are devices, commercially available devices like tube extenders. The same company which supplies Ahmed glaucoma valve also has a tube extender which can be used to effectively lengthen tubes of glaucoma drainage devices that have retracted. In spite of meticulous placement and placing it as close to the endothelium, as close to the iris as possible, tube corneal touches do occur, and treatment of choice would be to reposition the tube to a much more posterior location through a different sclerostomies. It's beyond the scope of this lecture to discuss tube exposure, but with the current episcleral technique of tube implantation, tube exposure rates have decreased, but still patch graft melt and tube exposures can occur like this. Another common problem with, especially with the valve implants, is to have a very thickened fibrous capsule around the end plate, also known as a tenon cyst or encapsulated blood, which leads to high intraocular pressure postoperatively. And rarely we might have to go back and excise a portion of the cyst underneath the conjunctiva. And finally, tube extrusions can occur over a period of time, especially in pediatric age group, and along with tube exposures pose a significant risk of late endophthalmitis in eyes which undergo the aqueous drainage implant. And when plates expose, once your plate exposed in an eye which has undergone an aqueous drainage implant surgery, there is no point in trying to repair this because the tissue integrity is compromised so much that you end up with having to remove the plate. So that was my last slide, and thank you once again for the kind invite.
Thank you, George. As usual, amazing videos and presentation. I would have a question. With this technique of without a cover, without a patch graft, how is it that you have an equivalent rate of success? Because in my limited experience, all the patch tubes without patch graft over time, over 3 to 4 years, have eroded.
Madam, the caveat is to have an adequate length and depth of the scleral tract, a minimum 4 millimeter. All tube exposures usually occur 4 millimeter, within 4 millimeter of the limbus. If you have an adequate tract of adequate length and depth to embed the tube in the patient's own sclera, the post-operatively what we see is the raising of tissue is much more, the tissue is much more flat, the inflammation is much less, predisposes to much more healing response. Again, the transition from the conjunctiva to the cornea is much flatter with better lubrication at the limbus. These are some of the hypotheses that have been told. And another important thing is having your tube in a 4 millimeter, has not fit in a 4 millimeter track. The micro movements don't happen here, unlike in a much smaller. So, and micro movements are supposed to predispose to tube exposures. What we have seen is the healing is, I've not put any of those poster pictures. And in this publication also, at the end of 2 years, naturally the eyes with patch graft were much more in number than the eyes which did not receive the patch graft. We started using this technique from 2016, early 2016, and I am proud to say that all consultants now go for this patch-free, flap-free tube implantation. Does it convince you that
tunnel technique at 4 millimeters, you create a single tunnel at 50%?
Yeah.
But if you have a tunnel as well as a flap, what is the problem in that?
Once you have
you have both. I think Dr. George, I think I was actually using scleral patches. I had one case of infection. Then after that, wherever the sclera is healthy, I'm doing a flap. I'm doing a typical scleral flap, and then underneath I'm going. I think this is an excellent modification that can probably be because it also reduces the surgical time. You don't have to fix the tube. As you said, it snugly fits into that area. I think it's a very excellent innovation, and it's time saving as well as probably, as you said, probably if it is comparable to scleral flaps, I think it's something worth trying in every case.
No, what I was doing it is with the minimal tubes we've done is a tunnel technique, just as you have said, 4 millimeters to 5 millimeters away, go in the tunnel half thickness, and then cover it with the cornea. We have this cornea which is not usable for any other thing. We have a scleral patch graft, we have a half thickness corneal cover. That's what I.
Yeah, that's right. See, whenever there's a tissue, it's a different. When there is when the shortage of grafts, where the things are not available, I think this is a very good technique. Thank you, George, for chipping in and giving this excellent tip for us.
Can I put in a word?
Yeah, please.
Okay. I would tend to agree with George because long back, Oscar Alves from Mexico had told me to try this, but it took me till the lockdown and I couldn't get hold of sclera to actually do it. So my follow-up is 2 months only. But the eye itself looks much quieter. We are not putting I suspect it's because we are not putting a foreign tissue, and it has been looking very good. But I don't have time. I don't have enough follow-up to say anything about exposure. The 2 cases I did, the anterior part of the eye is absolutely looking like it's untouched. So putting in a graft, I suspect on top of a needle track tunnel, I suspect may add to the inflammation. Because all my patch grafts that I put, it looks different in that area for quite some time. And I use it, what Oscar told me was to have at least 6 millimeters. So I go for a 6 to 6.5 millimeter tunnel. And it's not as difficult as you think. It just tunnels in very easily.
Yeah. Thank you. I think with the next module, probably people are waiting. We need to give some breathing time. I think I suggest to the chairpersons to kindly, we can wind up this session with such excellent talks which has delivered so far. Thank you very much.
Yes, thank you, everybody. So I don't think we need to have any formal leave taking, but thank you for everybody who's contributed. And I think it's time for lunch.
I think Gopal can have the last word when you can wind up.
Yes.
Take us to the lunch.
Yes, Gopal.
Tell us the menu beforehand.
Gopal is speechless.
Gopal, you can order Swiggy.
So thank you very much for joining. You can hear me, right?
Yes. We can see you.
Thank you very much for joining. This was a wonderful program of 4 hours. Actually, we overshot by about an hour. Actually, we have a little bit of a glitch. That is why we should close for maintenance before the next batch is on. First of all, let me, congratulate Dr. Andrew Braganza and Dr. Kirti Singh for directing this course really well. And all the speakers, I would say, right from Thomas to Kiran to Krishna Prasad, Abhi, Satyan sir, Andrew, everybody has really done a wonderful job. And these 4 hours of glaucoma teaching session will be available on YouTube for years to come for all the postgraduates and all the people. Actually, our standards towards the end of the session was as for a glaucoma practicing person. So thank you very much. And I thank Sun Pharma for for this help that they have. And I would I really appreciate Dr. John, Dr. Rajiv, and Dr. Prashop, who has done a lot of things behind the scenes so that this can be telecasted. And 2,000 people have watched this live on YouTube and Facebook today, and that's a huge number. And usually in no conference will such a jam-packed crowd be seeing all these. Thank you very much. We'll close for lunch.
Thank
See you at 2 o'clock.
Thank you.
Thank you.